and they usually always immediately plus comes. So that is the antenatal care. And whenever we think of that 4 antenatal checkup which are mandatory for the pregnancy, most of the care is limited to topsoil and weight management. So I remember Professor Gogusan's first tutorial class when we were students in the year 81, around 81. Sir, whenever that was the first class, I asked what are the things that you do in the antenatal OPD. That was the first question. So we were just students, so we do not know. SARS first wanted to know whether we see the weight or not. Weight is very much important, and today also weight is important. Though we have high-tech things, we are doing biochemical models. Weight is still important. Blood pressure is still important. And SAR used to ask about the investigation. What do you do to investigate in the antenatal matter? We used to say hemoglobin pass and ABRS, letter. Those are still there, but those are not still done at the periphery. That is our problem. We do not carry the message to the periphery. And in that way, if you think we should, from our different societies, we should have some more orientation program, more checkup. When I was with NHM and Jorhat, we had, because ANM are training different centers. We had a training for the ANMs only on antenatal care. How do you do antenatal care? How do you see examine the blood pressure? That's important. So not going into the details, maternal mortality is still, our population clock is still ticking every second, and that maternal mortality is still high. If you just compare it, our state is in the latest, which is around 190, 195, and India is 97, whereas if you see Kerala is 18 or Maharashtra, it is coming down. Maharashtra, even Gujarat, all states are coming down. So maternal mortality also directly related to the antenatal care. So I am just touching some of the points of antenatal care in this small short lecture. So whatever we are doing is it's a preventive health care, not only for the mother, for the baby. We are now focusing. Though the maternal mortality is coming down, perinatal mortality is still higher. Systemic examination, investigations, and advice to the pregnant women, early detection and fetal birth defects. Yesterday we had a very good ultrasound workshop, field medicine workshop, where we had faculties from AIMS also who focused on how can we detect earliest. We had faculty from Guwahati, we had faculty from Delhi, how we can early detect most of the defects even in the first trimester, or we can not only NT but beyond NT, some anomalies can be detected. So objective all of you know to ensure normal pregnancy and to deliver safely a healthy live baby from a healthy mother. So what we mean to say first trimester master checkup. Whenever we use some adjectives like master, you think that it is very high-fi things. But master health checkup or master checkup, what does it mean? It includes everything what we are doing, physical and detailed ultrasound, documentation also, laboratory investigation, including biochemical screening, identify early stage disease first visit. If CV is abnormal, we can go for investigation for anemia like ferritin, serum ferritin. Hemoglobin hepatitis is very common in some area, especially in the north. The thalassemia and some beta thalassemia. In our place also hemoglobin typing is very much important, especially in upper Assam area. Blood group and RS group and antibody scan. Yesterday, Aparna presented a very good case of how RS negative is important, how difficulty they faced during the COVID times in managing the inter transmission. So, blood group and RS negative, even husband's group is done, it is mediating. Antibody screening is must right from the early part of the pregnancy. CBC allows measurement of platelets, which may be useful. In many centers, they used to do routinely platelets because that also can detect some of the hematological disorders, for which we face later some problems. Urine analysis is must, including asymptomatic bacteria, which is very common first for fetal liver erosion. Urine ulcer with stream, then cervical cytology, country is a must. Chlamydial antibodies, others, syphilis screening, with status, hepatitis B, rubella antibody titer, hepatitis C. Gestational diabetes screening is very much important, as we for who's develop gestational diabetes in the later year. So OCDT or fasting blood glucose recommended screening for all, right from the first trimester was at least one checkup. Is also seen the NEOGSCON is seen. NEOGSCON is a very marker for how the pregnancy will go on afterwards. Then embryo, then nuclear translucence. This is very much important. Professor Kipros Nicholas first thought of it in the year 1991. If you just see the amount of thickness in the neck, you can detect a lot of chromosomal abnormalities later. So it will call the nuclear translucence, maximum thickness of the subcutaneous translucent area between the skin and the soft tissue avoiding the spine in the sagittal band in the neck. Done at 11 to 30 plus 6 weeks. So values will be, if it is more than 30 millimeter, it is not, it will be down, but you will have to go for some further test. It is a screening method only. So it does not confirm. So it is a positive screening test. For that, we will have to go for other biochemical markers, or we will have to follow the most common cause is the trisomy 21, but there are a lot of other pickup. So when NT is done, whenever the crown ground length is 45 to 84 centimeter, that 11 to 30. More it is nearer to 13 weeks, more lot of anomalies you can detect, especially the neurosonogram. You can detect a lot of anomalies. Corpus callosum is not from that part, but you can detect other posterior part of the brain may have some anomalies. In neutral position, whenever we take anti-scan, we need a lot of expertise because the fetus always moves. If you take in hyperextended part, that will not give you the exact one. Or it's test, you should take a lot of time. Yesterday in the WhatsApp they have seen it took around half an hour sometimes to take a good anti-scan. And anti-scan, how anti-scan, you should zoom the image in such a way that the head and the thorax is covered the whole skin. Zygoma is not seen, and it is the largest measurement. Transverse bar of the caliber should be in the white line. So this is the anti-scan showing. We should measure in a proper. Not only the head and the thorax part is in the monitor when you zoom it. So increase nuchal thickness. Maybe in the case of trisomy 21, we can, along with that, we can detect a lot of anomalies like cystic hygroma. One more minute. Yeah. Increase. So these are the causes for increased anti-oncolosis. You can see a lot of as you have seen. So cystic hygromas and hydrops can be seen. Biochemical screening, we always focus on double marker nowadays, PAP A and PITA. There is no role of triple marker. Double marker or quadruple marker. Nowadays, pentavalent also coming. So this NEOGSCON screening, I am not going into the details, but we can see the absence of nasal bone. Yesterday we detected one case. Then tricuspid valve is very much important. Dr. Spinosa's the nasal bone. How you see the nasal is another marker. So facial angle between these are the different centile in trisomy 21, 18. Dr. Spinosa's flow, you should take in the proper. So in this way, if you just see the reverse A, this is abnormal. This is the way for taking the doctors. You should have a proper angle of isolation. So another screening is for PIS. I'm not going into details. I think we have more discussion. Mean arterial pressure is seen. PLZF, placental growth factor, and the ratio between PLZF and SP, that is also soluble effectiveness like tyrosine kinase will give you a prediction for preeclampsia, serum endocrine, and a lot of other of eternal artery is very much important for prediction of PIs. So this is the take-home message. First semester must take up from an integral part of important part of prenatal care. Besides screening for common maternal diseases, it allows a thorough evaluation and assessment of the fetus by biochemical and other. we are having received from the second trimester NMD scan to the scan. Thank you so much.
Next, our next topic is categorization of LSCS, which will be deliberated upon by Dr. Saswati Sanil Chaudhary. May I request our respected chairpersons to kindly give a brief introduction about Madam before we go on to her session.
It's a pleasure for me to introduce Saswati, who happens to be a classmate of mine. We studied together from Cotton College to Jorhat Medical College, then again in postgraduate studies. She is presently the professor. She is chairperson of she was the chairperson of Medical Education Committee for 3 years for Foxy. Then presently she was also the vice president for ISOPAR. I think she's still presently the vice president of ISOPAR.
No, I have been.
And apart from the real introduction would be, I know she is an acclaimed academician, very strict professor of obstetrics gynecology. Anyone who has worked with her will understand how it is to work with her day and night. She's got, the unlimited energy for patient care, morning, night, it doesn't matter. So that is that signifies her in the department. Everybody knows such thing. So I think she is going to tell us all about our CS, what to do, what not to do.
So first of all, I feel really privileged. Thank you, Chairperson, for giving the introduction. And I really feel privileged to be one of the speakers in this prestigious MP Gogoi Padma Shri MP Gogoi Memorial CAV. And I have not seen a versatile person like him in my life. And I have seen sitting in one's seat, he's giving 4 people in different language, different kind of dictation and different kind of advices and different kind of, also asking patients and students about the questions and all. At one point of time, hearing so many things admire. I have not seen a person like this. So yes, because the matter of concern for nowadays, if you see from 1940 to 1950, the incidence was only 5%, and then 70s, 80s it was 15%. Presently, 20% and some places 30%, but that is an overall. But if you see the referral colleges, medical colleges, so for example, in our section in second stage, it came out to be at around 1.8%. Now, WHO guidelines, WHO say that the US Health Initiative 2000, it should not be more than 15%. And when this EFM, that is electronic fetal heart monitoring, came in 1960s, the increased the rate of cesarean section, but there is no reduction in the incidence of cerebral palsy. So that's the matter of concern. Then we had 2001, we had the Robson's classification. But before Robson, it was Lucas who proposed a new classification, which is consisting of 4 categories. That is dependent on the decision to delivery interval. Depending on the decision delivery, which stage, what is the interval you can allow from the decision to the delivery, that depending on that, they had categorized this cesarean section. The purpose of this classification was to minimize communication difficulties relating to urgency of the delivery between and within the teams, and identify specific cases requiring immediate delivery, which is the category 1. Then the data collection and audit of the outcomes. Now, depending on the urgency of the LFCS, they are divided into category 1, category 2, category 3, and category 4. So category 1 is emergency. Then category 2 is the urgent, category 3 is scheduled, and category 4 is elective. So in emergency, there is immediate threat to the life of the women and the fetus. The urgent is maternal fetal compromise is there, which is not immediately life-threatening, and scheduled is needing early delivery, but no maternal or fetal compromise, and elective at a time to suit the woman and the maternity team. The Royal College also had they had in their good practice guidelines, they have given this that's they have given the green zone, which is there is no maternal or fetal compromise, which goes to the category 3 and 4, and fetal and maternal fetal compromise, which goes between the 1 and 2, and which falls in the red category, that is in the immediate threat to the life. What are the issues? If we go for the emergency cesarean section, what are the issues? Let us see what are the issues there. The safety, the spit, labor room and OT protocol, fetal-maternal complications, and what are the medical legal issues? The rapid delivery, the issues are increasing the risk of maternal mortality of surgery or factors such as general anesthesia, because the patient has not been screened for whether she is fit to give anesthesia. And in developing countries, the incidence of emergencies, cesarean section is going high because of the insufficient prenatal care and poor referral system. They come very late to us, so it is always an emergency. You have to go fast as early as possible. Now, this is the National Institute of Childhood and Human Development in 1999. What they have seen that they have divided in this emergency group of cesarean section, a group where this. And they have seen the outcomes like endometritis, complications, operative injuries, cystotomy, bowel lacerations. There is no difference in this. If you see the p-value on the right side, there is no difference in the outcome regarding to this. But if you see that red area where the umbilical artery pH less than 7 and intubation in the delivery room, that is highly significant. The p-value is 001 and 004. That means if you do the cesarean section within the 30 minutes, the outcome will be better. And if it is more than 30 minutes, that is the outcome will be not good. So these are the category 1, immediate threat to the life of the human fetus. We know these are the all. So I don't think I will utter all this because of this, you know, the indications. And the NICE guidelines, they say the category 1 cases, actually delivery, ideally you should do within 15 minutes, but not to compromise with the mother's well-being. But sometimes this 15 minutes DDI target may not be achieved because for these reasons, one audit standard of 30 minutes has been proposed by NICE. Now, this DDI has been changed over time. In 1957, it was thought to be, it should be 43 minutes if it is an emergency case, and it ranged from 15 to 95 minutes. In 1960, they said it should be 12 minutes, and 1984, that it came in UK, they have said that it should be 30 minutes. But 30 minutes rule, this 30 minutes dictum, it has come from the study that I have told you. So any hospital providing an obstetric service should have the capability of responding to an obstetric emergency. So any hospital who is delivering the maternity care, they must have some kind of management system where a cesarean can be done within that 30 minutes. ACO, the professional standard, they also stated the same thing. The 30-minute response time has become a medico-legal benchmark for adequacy of the obstetric care when cesarean delivery is indicated. The why 30 minutes that I have already told you, that grade 1 and grade 2 cesarean section, maternal and perinatal outcome deteriorate measurably when the decision delivery exceeds in 75 minutes. For category 2, the ranges can go to up to maximum is 75 minutes. But even in UK, only 63% of UK obstetric unit, they could do the cesarean section within 30 minutes. That is only 63%. Because there are a lot of complicated tasks before you go for an emergency, and these are complex tasks. So, including the assembly of the staffs, you at least need 7 professionals to be there: anesthetist, skilled assistant, obstetrician, and assistant, theatre nurse, midwife, pediatricians. Then anesthetist to be informed, operational department assistant informed, consultant to be informed, anesthetist to arrive, and theatre to be safe. Scrap, pack, sutures, these are all to be has to be open. Monitoring to be discontinued if somebody is on the fetal sampling, those things has to be removed. Intravenous lines to be secure. Then what is that has to be done? Because there are also these issues are there. You have to take informed consent from sign, intravenous access, intravenous fluid, pre-medication injected. Then woman has to be moved to the theatre. This is another important area. That if from the labor room the 10 minutes is elapses, when it is considerably less likely that a baby will be delivered within 30 minutes. So during that emergency cesarean section, whatever the checklist you have, that also has to be kept short so that you can reduce the DDI. Then these are the tasks: spinal cap open, anesthetist root cup, drugs, monitoring, spinal anesthesia, pediatrician, catheter. If you see the whole of all the work, everything, if you put at least 1 minute, so many things are to be needed. Of course, multiple persons are doing it. The reasons cited for failing to meet the recommended DDI are anesthetic delay, incomplete surgical team, unavailable operating space, patient transfer to the operating suite, that is the transfer time, and hospital funding cannot afford a standby team. So there's medico-legal aspects, that is Royal College and Anesthetic Association and Clinical Negligence Scheme for Trust. They have quoted as suggesting negligent care should a baby be born in suboptimal condition when there has been delay of more than 30 minutes, you are liable to be sued. And time interval plays an important role in court cases, whereby the defined time is supposed to serve as a point of reference, and the constellation in each case ought to be evaluated individually. Emergency surgery is associated with higher morbidity and mortality, as there is no time for preoperative preparation. Now, anesthesiologist has a role to play. They reasonably guard their right to ensure that they use the safest procedure for the mother, yet they are expected to do the complex task under pressure of time. The confidential inquiry to stillbirth and death in infancy recommendation include the advice that only one attempt of spinal anesthesia is appropriate when the general anesthesia poses no great risk. So multiple punctures are also sometimes cause these delays. And this is said that delay more than 15 minutes documented due to multiple attempts in spinal anesthesia. And delivery is thought to take 15 minutes longer with spinal rather than general anesthesia. So the responsibility of the anesthetist should participate actively in the resuscitation of the fetus in utero because it is in distress. They will do the relief of the autocaval compression was very, very important. And if the patient is already in epidural, the top-up dose with levobutyroxine is to be given. Then application of, these are the preparations. Application of the fetal scalp electrode allows an accurate recording of the fetal heart, as opposed to the often ineffective, incomplete, and inconclusive annual auscultation due to active uterine contractions or anxious, restless patients. So this is not possible, but maybe some point of time we'll be able to do this. Sometimes the fetal heart sound will recover sufficiently to allow a slower and safer approach to the cesarean section, or alternatively confirm the need for an extreme urgency. So it is always that we can see that it is a routine, all of us, we see the fetal heart sound on the table. Then anticipate the need for general anesthesia. So you should give her oral antacid, sodium citrate 30. At the time of decisive pelvic examination, when the decision to move the emergency CS in the obstetrician or midwife nurse should quickly and with full aseptic rituals. And the drills has to be done so that people know who is going to do what kind of work. That decreases it. So this, I have already told you that India has no maternal complications, but 95% of the infant delivered after 30 minutes did not have compromise. But again, even if 30 minutes DDI fit, but efficiency of unscheduled C-section improved from 36 to 59%, but within that delivery, even if you deliver, it does not guarantee that there will be no adverse outcome. So this is category 2. And the NICE says category 2, the time limit is 75 minutes. These are the category 3, macrosomic and all these things. These are all, then comes the category 4, which is the time to suit. These are all category 4. But the timing of elective CS that I want to say that it should be done after 39 weeks of delivery. Why? The incidence of respiratory model, you see 7.4% to 11.4% if it is done at 37 weeks. And it is 4.2 to 8.4, double, even if you do at 38 weeks. But if it is done, it is 0.8 to 2.1. So it is almost 0.8, it is 1 to 2. But even then, at 39 weeks, also if you do, the chances of admission is this. So the NICE guidelines say no restriction for the timing of elective CS for post-CS. For post-cesarean section, what should be the time of elective cesarean section? So even that also they say it should be 39 weeks. Some might conclude that due to various fetal and maternal weeks, 39th week is the optimal time, not after 39, but it is at 39th weeks for a previous CS, which may reduce the incidence of rupture uterus. So NICE is always connected with various stresses. It may also negatively affect the long-term development of the neonate. So even if you do at the early, we think it is term, there is a chance of an ICU problem. And moreover, the outcome of hypoglycemia is a surrogate for neuronal energy and may affect neurological development of the neonate. WHO say, the official WHO statement reads, there is no empirical evidence for an optimum percentage of cesarean section rate. What matters most is that each and every woman who needs CS should receive it. Each case should be managed according to the clinical evidence of urgency and tailored according to the clinical situation. So should always be considered as one of the important factor, DDI. And conclusion is joint guidelines says case-by-case approach in deciding the specific DDI. And this is the Lucas classification. And for emergency, it is 30 minutes. And there seems to be benefit in facilitating intrauterine resuscitation where feasible. And simulation training for enhances knowledge. And unit should define the roles of each member of the multidisciplinary team for effective communication and management. So need of the audit is to frame, teach, and implement guidelines and protocols. And our aim to make it delivery, whether vaginal delivery or to make it safe cesarean section. Thank you so much.
Thank you. Please.
Thank you, ma'am. So our next speaker for this session is Lakshmi Kukan ma'am. Ma'am will be talking about the silent fetal-maternal hemorrhage. I'd like again our respected chairperson to kindly introduce ma'am.
Dr. Lakshmi, she is a graduate and postgraduate from Guwahati Medical College, and at present she is the president of Guwahati Obstetric and Gynecological Society, and she is a consultant in Guwahati. And but the most important part I like to highlight, Lakshmi is associated with so many academic activities. She used to organize so many activities, and she always keeps herself very much attached to all the academic events. Anywhere I go, I always meet Lakshmi in all the academic events. Here the Lakshmi will present today on very important topic, which is the silent fetal-maternal hemorrhage.
Thank you, Arun, for these kind words. I'm really thankful to the organizers for giving me the opportunity to be a part of this wonderful CME in the name of Professor Gogoi sir. So when we joined as a house surgeon and we served as the HOD, and after that he took retirement. I think we were the last batch to be associated with him, and it was a great pleasure working with him. So now my topic is silent fetal-maternal hemorrhage. As the word says, it's silent. We don't know when it happens, but sometimes, most of the time, it is not significant, and sometimes it has a very catastrophic consequences. So it's a it happens in many, it's a high number of pregnancies. The insignificant happens. It's around 75% of the pregnancy. Clinically significant fetal-maternal hemorrhage occurs in 3 per 1,000 births. It's the figure is not that uncommon. So, I mean, when we classify, say sometimes it's massive, but definition is not very clear. Some people say that when the fetal-maternal hemorrhage is more than 30 ml, then it is clinically significant, and it is when it is more than 80 or 150, this is lethal. It may be spontaneous without any event, but sometimes it is traumatic, either doing some trauma during pregnancy or any other procedures, inter procedures like amniocentesis, chondrocentesis, external encephalic persons and all. And sometimes it may be acute or chronic. Acute, there is rapid loss of blood from the fetal side, ultimately leading to perinatal hypoxia, can lead to severe anemia, even fetal death. So when it is chronic, it's a recurrent and intermittent compensatory increase in the hematopoietic factors, then leading to fetal anemia, and severe cases there may be hydrops. So why we are so much concerned about it? Because when this happens, mostly in the Rh negative mother, it has got a lot of fetal complications. When we see that this slide shows that it is maximum in the third trimester, this action takes place maximum in the third trimester and least in the first trimester. The causes may be the maternal abdominal trauma like motor vehicle accident, fall, abuse and assault, placental factors like placenta previa, abruption, tumors, umbilical vein thrombosis, and obstetrical procedure as I have already told. So risk factors, like everywhere we can put race, socioeconomic status, and geographical variation. I don't know how it really affects the fetal-maternal hemorrhage. Obstetrics procedures, and like these are all risk factors. So, what is the pathophysiology? Pathogenesis of fetal-maternal hemorrhage is unclear. There is a normal placental connection in trophoblastic layer allows minute bidirectional blood flow between the mother and the fetus. So when there is a breach in the placental trophoblastic barrier, blood cells move to the higher pressure of the fetal circulation in the lower pressure of the intrafetal space, and ultimately it leads to the maternal circulation causing temporary maternal chimerism. So this is the slide which shows the prevalence of Rh negative population. We are lucky that we are in the eastern part, it is quite less. It's about 2% in comparison with the northern India, which is as high as 7%, and southern western India it's 5%, and southern India it is 6%. So in that case, we are a little lucky. Clinical presentation, patient may present with massive fetal-maternal hemorrhage may occur with or without any symptoms, and sometimes they present with decreased fetal movement, and which will, when we do the CTG, we might say that there is sinusoidal fetal heart pattern. In severe cases, there may be fetal hydrops, fetal IUDs. Most important, and we can demonstrate, is the elevated middle cerebral artery Doppler. So, and that another thing is the early neonatal anemia. So, whenever we get a patient with a trauma, then we must assess the woman first with airway, breathing, circulation, and disability. When we should consider the diagnostic test for fetal-maternal hemorrhage, there is an unexplained stillbirth, persistent maternal perception of decreased fetal movement, hydrops, unexplained elevated middle cerebral artery Doppler, and which is the consistent with fetal anemia. And another is neonatal anemia, because fetal anemia causes increased cardiac output, and there is less viscosity, which will cause the increased PSB of the middle cerebral artery Doppler. So diagnostic, when we assess the mother, we have different tests like Jorhat test, flow cytometry, and Rosette test, which will how much fetal blood is there in the maternal blood. So another is the fetal testing may include CTG, obstetric CVG, and diagnostic modalities. Other are the assess the mother. So clear Berkey test will simply tell us whether there is transfusion or not, and there is but they have some fallacies. As the pregnancy advances, there may be fetal hemoglobin decreases. Most accurate is the flow cytometry, which will tell us the amount of blood, but this is not very universally accepted. Rosette test is another one which will test how much blood is there in the maternal circulation, and whether we'll need additional anti-D injection in this group or not. So, like for the fetus, I have already told about CTZ, but it has the lack of reproducibility. Then chordosynthesis, yes, we can do the chordosynthesis, but it's a specialized test, not available with everyone. We need a good fetal medicine unit, and there we can, suppose we get there is fetal anemia and fetal maternal hemorrhage, we can start IUT, intrauterine transfusion. So suppose we detect fetal maternal hemorrhage, pregnancy more than 32 weeks, and fetal maternal hemorrhage is more than 20, immediate cesarean section is recommended. Less than 32 weeks, severe fetal maternal hemorrhage, IUT is recommended. More than 28 weeks, we can also, suppose we don't have a facility for IUT, we can go for C-section with corticosteroid and Mexsurf. So IUT, repeated IUT sometimes may be indicated, and I will just go to the recommendation. So ICOG, FOXY recommendation in the first trimester, when there is episode of bleeding, including MTP, ectopic pregnancy, the prophylaxis dose is 50 to 100 microgram. And the second trimester, all pregnancy should test it for RH sensitivity, and the prophylaxis RH anti-D should be given at 28 weeks. And trimester amniocentesis, abruptio placentae, or IUD, 300 microgram should be given for every additional 0.5 ml of RBC. A dose of 10 microgram should be given. The prophylaxis anti-D at 28 weeks is nowadays is recommended and should be practiced. So, but in India, we can see that very few of us practicing this antenatal prophylaxis, and I think this should be practiced. It's well, and it is cost effective, and it will save the baby. So, blood group should be as it is done in older women, and ICT is to be done in the very first visit. If it is negative, then repeat ICT at 28 weeks with the anti-D injection. In case of women who has anti-D immunoglobulin, either following a sensitizing event or routine antenatal prophylaxis, subsequent ICT is not preferred, and it should be referred to the fetal medicine unit. If ITC is done after anti-prophylaxis, it should be interpreted with a specialist consultation. So at the time of delivery, RH negative mother documentation of the blood group and RH status of the neonatal is a must and to be done. The sensitizing events requiring anti-D prophylaxis before 20 weeks is 150 micrograms. All those events like significant bleeding during threatened abortion, spontaneous miscarriage, ectopic pregnancy, hydatidform mold, CVS, embryo reduction, amniocentesis, and other invasive fetal procedures. And when it crosses 20 weeks, abruptio placentae like brown trauma, intrauterine fetal demise, external cephalic version, placenta previa and bleeding, then 300 microgram is indicated. The FOXY has recommended routine use of RH and immunoglobulin. RH and negative women may have still bleed silent in the third trimester, resulting in isoimmunization. And in order to prevent it, anti-D prophylaxis should be done. A single dose of 300 microgram IM, preferably in the deltoid, is economically effective and is better compliance. So this is the flow chart which shows the woman with blood group and antibody screen in pregnancy confirms Rhd negative, antibody screen positive for anti-D, clinical history, previous pregnancy, transfusion, and you exclude all these things, recent Rhd with the laboratory to determine whether to be passive or performed preformed antibody. Likely to be preformed anti-D, yeah, if it is likely to be preformed anti-D, Rhd IgG not required. It seeks specialist consultation. So, and antibody screen negative for anti-D at 28 weeks, you redo the ICT but give the anti-D. If it is, suppose ICT is positive, then you consider the clinical history and consider, talk with the laboratory people. There is a likely possibility of preform. Again, you go to the fetal-maternal unit and refer the patient for the fetal medicine unit, sorry. So if it is negative, after birth, cord blood is taken, go for the grouping of the, then if the maternal blood sample volume is more than, the fetal-maternal hemorrhage, the fetal blood is estimated to administer Rhd 300 microgram to the woman as practical without waiting for the result for the fetal-maternal hemorrhage. If delayed beyond 72 hours, the dose should be given up to 28 days. If large fetal-maternal hemorrhage, follow laboratory or medical advice regarding the additional Rhd to be given. So additional Rhd for sensitizing event in singleton and multiple pregnancies, we have already said, first 20 weeks, administer Rhd 150 microgram as soon as practical. If delayed beyond 72 hours, and it should be given up to 10 days from the sensitizing event.
1 minute.
Yes. This is last slide. So after, unless testing has confirmed, then they are carrying Rhd positive fetus. If delayed beyond 72 hours, then it should be given within 10 days. So most of the fetal-maternal hemorrhage remains asymptomatic and underreported. Mild fetal-maternal hemorrhage is seen almost in 95% of the pregnancy. However, 1 in 5,000 deliveries, 5,000 deliveries have severe fetal-maternal hemorrhage, that is more than 150. Placental trauma, abruption, architectural disturbances, tumor, etc. may cause fetal-maternal hemorrhage. Diagnostic technique for fetal-maternal hemorrhage are expensive and is not universally available. And the fetal-maternal hemorrhage lead to immunization, hemolytic anemia of the newborn, neonatal anemia, cardiac and the injury. Respiratory distress is some of the cases in fetal death. Intrauterine transfusion has a successful rate diminishing the fetal distress due to fetal-maternal hemorrhage, but it is not widely available. Research isoimmunization in Rhd microgram and recommended to all non-sensitizing mothers after 28 weeks of gestation. More research is needed in this field. Thank you for your patient hearing. Thank you.
Actually, and the next session has to start at this time. I'm sorry we won't be able to allow questions. But, I know there will be many questions. Delegates are advised to just speakers are here only meet the speakers and the queries. Because our virtual session, I am told is will start at 12 noon. So just 1 hour for the next session. I speak for both of us and to be the opening person in this prestigious MP Gogoi Memorial Forest.
And a photo group.
Yeah, thank you.
Speaker and chairperson. Will you allow that kind of activity? Yes. And with the background, when it's CG Sarai singing, background to be.
Speaker 9. এইটো সেশনৰ মাজতে দিব কাৰ কেমেৰাটো লৈছে নে কেমেৰাটো কাৰ মোবাইল
গম নাপালো
We all set now to move into our second session. At the very outset, I'd like to invite our chairperson to chair this session. May I now request Professor Bupul Sundar Das sir to kindly come on the dais and take his place as the chairperson. Das sir is currently the Officer on Special Duty, Srimanta Shankaradeva University of Health Sciences, Guwahati. He is a founder professor and HOD Department, TRIMS, Naharlagun, Arunachal from 2018 to 2020. Dasa has been the professor and head of the Department of Obstetrics and Gynecology 2012 to 2015, Guwahati Medical College and Hospital, Guwahati. He is the officer in charge, Fields Unit, Guwahati National Institute for Research in Human Reproduction, ICMR, Mumbai, 2012 to 2017. Sir is a Vice President, Federation of Obstetrics and Gynecology Society of India, 2014. He has been the member governing body, ICOG, 2014 to 2016. Sir has been the President, Guwahati Obstetrics and Gynecology Society, 2012 to 2014. Sir has been the President of Association of Obstetrics and Gynecology Society of Assam and Northeast. He has delivered guest lectures, oration panelists in national and international conferences, published chapters in Foxy publications, and published articles in national and international journals. We are really delighted to have you, sir, as our chair today. Our next chair, I would like to invite Dr. Jiten Gogoi, sir, to come on the dais and chair the session along with Gokul Das, sir. Jitendranath Gogoi, sir, is an MD, FICOG, FICMCH, Diploma Laparoscopic Surgery from Germany. He has been the past president of Jorhat Obstetrics and Gynecology Society. We thank you, sir, for giving us your valuable time. Our third chairperson for this session is our very known to Professor H.K. Sharma, sir. Professor and Head of the Department of Obstetrics and Gynecology, Jorhat Medical College and Hospital. Sir is the Editor-in-Chief of the New India Journal of Obstetrics and Gynecology. He is the Founder President of Barpeta Obstetrics and Gynecology Society, which is affiliated to FOXY. Had performed more than 100 cases of VDF surgery, innovated some methods of repair. Has performed 150 cases of radical hysterectomy, innovative techniques of radical hysterectomy. We thank all our chairs for gracing the occasion. Now, into the scientific session, may I now request our first speaker, Dr. Pranoy Phukon sir, to deliver his topic on adolescent gynecology in reference to lung abdomen. May I request one of our chairperson to kindly introduce Dr. Pranoy Phukon sir before he delivers his address.
Good morning, my dear friends, delegates, and our seniors. It's a very august occasion for me to be chairing the session. And Dr. Jitan Gogoi again and me, we have got very, very fond memories of working with Sir as opposed to students. Well, words cannot express our feelings for Sir. Anyway, I feel very proud to introduce Pranoy Phukon. He is an associate professor of ONG Department, Assam Medical College, Chittorgarh. He is a teacher of undergraduate and postgraduate for 32 years. He is a university examiner of MBBS and MS and a PhD. He is a visiting professor of FOXY in 2015-16. He is president of Dibrugarh ONG Society in 2022. Honorary Secretary, Dibrugarh Menopause Society 2021. Publication of more than 25 original papers in national and international journals. Peer reviewer of national and international journals. Special interest in infertility and endometriosis. Trained in Boston, USA in infertility. Contributors to chapters in postgraduate books in gynecology and pediatrics. Assistant editor of Handbook of Infertility for Practitioners published in 2021. Organ secretary and chairperson of many ONG conferences and seminars. Is a resource person, radio and television program on health awareness. Besides, is a well-known Hitikbulikom, Kobibulikom, or Dan Kobita, and the police, Hodai, Dan Kodita, Hodnabase, or Kikopta, who Hitikbuli more kind of basic, use a full kind of basic. Thank you very much. Postgraduate student in Nordra, Thank you. Welcome.
Thank you, sir. Thank you for your kind words, my teachers and my delegates. Good morning to everybody. I have been told to speak on adolescent gynecology in reference to lung abdomen. The time is very short. It's a very big subject. Touch on the epidemiology, the difference of diameter lung, investigations we should do, and management of basically few conditions like how to manage a benign ovarian cyst in the adolescent age, a malignant ovarian tumor how to manage, and torsion of the ovarian tumor how to manage, some new concepts, and endometrioma. So majority of the adolescent people, they have the pelvic lump. Most of them are ovarian cysts. We know it, and we should know that in adolescent, half of them, more than half, that 60% are benign, or half of them are probably these are functional cysts. So we should not be very scared about the neoplasm or malignancy. The most common benign cyst is cystic teratoma, and most common malignant tumor is germ cell tumor. And adnexal mass is often present management dilemma in adolescent. We are confused when a young girl is coming with a lump abdomen, whether it is an abdominal lump, it's a pelvic lump, it's origin, where it origin. So etiology is very difficult to find out sometimes. Recently, I have seen, I don't know, but I was not noticing when I have been told to speak on the topic. So I have started seeing the patients every week in my private chamber as well as government hospital. We are getting 1 or 2 patients every week of lump abdomen adolescent. So incidence is not really low as we think. So ovarian malignancy is 1.1% of all malignancies of the adolescent. So it is relatively less. And differential diagnosis, of course, we have to include the list of conditions of non-gender symptoms. So ovarian causes may be functional cyst, most of the cases. It may be para-ovarian or paratubal cyst, and tumor may be benign or malignant. Of course, we shouldn't forget about the hydrosalpinx, ovarian abscess because of tuberculosis and all. Sometimes the even come with ectopic pregnancy, and then uterine causes like leiomyoma or hematometrite congenital malformations. Intestinal causes are also there, and urinary conditions like pelvic kidney hydronephrosis, Wilms tumor, these are also to be ruled out. So ultrasound is the best method to diagnose at this age after besides clinical examination, and we know all the features very typical. This is a simple cyst. What is a fissure? What is a mucinous cyst? It was septed, and there's a dermoid. There's a solid component there, and of course, malignant tumors will get that typical picture. A solid component, nodular, vascular flow within the solid component is very high, and thickness of the septation is more than 3 millimeter. And of course, sometimes there might be ascites when it's a malignant condition. So IOTA is a sonographic procedure. We, as a gynecologist, we should make our radiologists sensitive that when we are sending a patient for ultrasound, at least they should try to find an IOTA. And I know that all our gynecologists now, we are now acquainted with the IOTA, and IOTA is very helpful. If we get any rules, malignant or benign, it is definitely helpful for us to diagnose the malignant condition or benign condition. So my idea is when I send the patient to sonologist, something that specially we have to write, please do IOTA screening. So IOTA intervention is very good. It's a one or more M fissures, it's a malignant tumor. One or more benign fissures, B fissures, benign tumor. Of course, both M and fissures are there indeterminate. The difficulty and sensitivity and specificity is very, very high. Recently, in the last 2 years, we are doing some IOTAs in our hospital, the postgraduate thesis, and we are very happy with the IOTA screening. So, what's the role of tumor marker when you get a lump in the adolescent? The CA-125 you should do in all cases, but this is not the important tumor marker for adolescent age group. Adolescent age group, basically, we know that this is the commonest tumor. So, alpha-fetoprotein and LDH, these tumor markers are to be estimated. So, we have to that list. Out of this list, most of the tumor markers we do it like CA-125, alpha-fetoprotein, lactate dehydrogenase, HCG, inhibin, and even mammalian inhibiting substances and carcinoembryonic antigen. These all the tumor markers are available in the hospital, in the laboratory, but selectively, probably, if we get a confused tumor, we can go for all this. Benign cyst management is definitely laparoscopic is the method because it's a young girl, and then we are all doing it how to give incision, especially the equal dissection is very important. And all of us who are doing laparoscopy, we always put 20 units of vasopressin in 100 ml. Myself, we do 100 ml. Some people they go for up to 400 ml also, and you just put the just below the systole, and then definitely the equal dissection will be very easy. And in the big tumors, of course, we have to do decompression. Suppose more than 10 millimeter or 15 millimeter, 15 centimeter tumors. In those cases, you have to make a nick and then just suck it out. But the spillage also should be taken care of the spillage because spillage of the ovarian content may lead to some of the condition. It is said that if the dermoid is there is spillage, around 5% of the cases they might develop. Only 5%, remember, it's not much high. So one should not be very scared about that. If you are just functioning at dermoid also, so it can be cleaned very nicely with having a expected solution. So anyway, this decompression is also important sometimes for big tumors so that you can take out the systole very nicely. Of course, when the patient is the malignancy, we have already told that germ cell tumors are most common, and in those cases, of course, we have to do the oophorectomy. Only cystectomy is not adequate for that. But when we do oophorectomy, it is not a radical surgery. It's not like staging laparotomy we do in adult patient. So we have to be careful so that only the ovarian disease ovarian is removed. Even the tube is also they say that it should not be removed. Because if you don't remove the tube sometimes may cause, may help in the getting pregnancy from collecting the ovum from the other ovary. So even the tube also to be spared in the patient, young patient. So oophorectomy without salpingectomy, And ureter are to be very important because if we just get the ureter, if it is necessary, we should not hesitate to go to the retroperitoneal space and then dissect the ureter. Because if we just clamp the infundibulum pelvic ligament at the higher level, then probably the remnant ovarian problems, that ovarian part which is retained, that can cause again recurrent, that can be taken care of. So one have to be very careful to even, we have to follow the infundibulum pelvic ligament as high as possible, and then we have to take care of the ureter, and then you can clamp and cut it. Ovarian torsion is another problem. So most of the adolescent lump, they come with ovarian torsion. So torsion is, because of the torsion, there will be venous return is compromised, and as a result, there may be some arterial still there. So etiology of the torsion is either anatomic or pathologic. Only 50% cases of torsion in adolescent people, they have the torsion because of pathological ovary. We should remember. So 50% of the cases of torsion ovary, they are simple follicular cyst, maybe torsion. So it is not like adult patient. So some of the physiological conditions are more than pathological conditions. And torsion is more common in the right side, we all know, because of the attachment of that intestine on the left side. And the adolescent, half of the cases associated with cyst or neoplasm, half not. And the other half normal ovaries. So torsion to diagnose, ultrasound will be the best, but we have to rely on patient history and examination. Color Doppler sometimes may be helpful, may not be helpful. And then there is a ovarian torsion complex composite index, we call it OTI. This ovarian torsion composite index is also very helpful to find out whether the patient is having torsion or patient is really liable for torsion or not. One of my postgraduate students last year did one study on this ovarian torsion composite index, and in that study we have found that pain is 48 hours, more than 48 hours is the number 1 point, associated in all cases. And then nausea is one thing in 87.5 cases. Ovarian volume is more than 70 ml. It is in almost all cases, and ovarian ratio, the normal ovary, disease ovary, the ratio is more than 10, in 62.5 cases. So ovarian torsion complex composite index more than 6 and a maximum accuracy of 94.87%. So Doppler is, I told you, sometimes it may be helpful, sometimes may not be helpful. But the most important thing, when you are getting a patient with in torsion, what to do? First, we have to inspect very thoroughly. That is the ovary. Probably, if we just open the abdomen and then you can see, or you can do a laparoscopy, we don't think that this ovary is going to survive. But it is not so. This is the ovary that we do the retorsion, and after that, of course, there is a good recovery of the ovary. This is one procedure called ovarian bivalving operation. If we do laparoscopy, even in laparotomy, we just give one incision with a hook, laparoscopic hook. In one incision, after that you have to wait for some time. And when you are giving the incision over the ovary, then if we get some fresh blood is coming, that's very important. If fresh blood is coming, it indicates still the arterial blood flow is there. That's very, normally we get a very black cavernous ovary. It's a hopeless ovary, just cut it and throw it, but it's not so. We have to give incision, even if necessary, we can give 2 incisions on both sides, and that's bivalving you do. And if you get some fresh blood, you can see oozing. That means this ovary is having normal blood supply, and we can keep it. So by doing ovarian bivalving, we can just see whether the ovary is viable or not viable. But one should be careful. We should be confirmed by, palpating the ovary as an inspection. It should not be malignant one. Of course, before that, you have to do some investigation to know it. So changing trend. For last couple of years in our unit, especially in our medical college, we are doing only detorsion. We are not doing any salpingo or oophorectomy in torsion ovary. My the registrar is not here, of course. Bonora is there. Of course, we are doing it for a long time. The previously we used to cut the ovary, but now we just do detorsion. And after detorsion, after 36 hours, it should be inspected. But we do not do that in medical college. But if I call the patient after 3 months of the surgery, I find that absolutely the ovary is not functional. So that should be the new concept we should now take. That all these torsion ovary are not to be removed, especially when it's adolescent girl. So when there is malignancy, of course, staging completely, I told that after the staging surgery, it should be very careful, you have to remove it. And most of the germ cell tumors are immature, disseminoma, yolk cell tumors, choriocarcinoma, and amyloid carcinoma. Those are the commonest tumors. Next is the endometrioma. So endometrioma is so said to be rare. Only grade 1, grade 2 endometriosis is there in adolescent girl. But in some women, we get even endometrioma. 5 centimeter, 6 centimeter up to the age of 19, 18 is very common. It's not uncommon. So if you get an endometrioma, what to do? The tumor markers are really always confusing because we know that tumor markers may be raised in other conditions like malignancy or even infection, even tuberculosis, peritonitis, many things. So it is not at all reliable, but tumor markers are reliable to see the severity of the endometriotic conditions. A possible risk factors of surgical procedures. When we operate in the case of endometrioma, again we should be careful because in a young girl, reduced ovarian reserve may be a problem. So in those cases, though we don't have the facility, but Western countries they think about the freezing of the oocytes. That is part of the sparing is very important, and fertility preservation should be considered. And of course, anti-adhesion measures should be taken, and ovarian suspension, whether it is useful or not. But many people they just hang the ovary in the abdominal wall just to get rid of the adhesions postoperatively. So we all know that when we are operating in the case of ovarian endometrioma, especially in case of adolescent girl, either cystectomy or ablation by laser, we are not having it, but some institutions with endoscopic surgery they are doing it, or even by plasma energy they use procedure. And most of the cases, of course, we go for electrocoagulation, but this should not be ideally done. We know that cystectomy has got the lowest recurrence rate. The recurrence rate is around 50% in cystectomy, around 70% in case of cyst or ablation, and around more than 80% in case of just drainage. These procedures, cystectomy you can do, but electrocoagulation we should be careful because we are more prone to use the high electric power. The electric power should be minimum, and then when we are touching the cyst wall with the electrodes and our diaphragmatic cord, then this task should be very minimum, and it should not be very deep also. If we just go doing that deep diaphragm, that can lead to the destruction of the ovarian cortex. And if we do, I have started doing the serum MS level before surgery and after surgery. And in cases of serum MS level, most of the cases it is always reduced. Just before operation, you do a serum MS level. After 2 or 3 months, if you do a serum MS level, it is almost always reduced. So all kinds of surgery can lead to loss of serum MS level. So combined technique is very important now. How to do a combined technique? When there is a large endometrioma, it is practically everybody is doing. I did not know that this is an accepted method now. First, we have to do the cystectomy. So if you are going to follow the cyst during the in the hilum area, the attachment is so hard. If you try to pull it, then it just starts from the ovarian hilum, and there is severe bleeding. In that part, you just do diaphragm, bipolar, and then remove the cyst. So combination of cystectomy and diaphragm is a now accepted method, and by doing that, you can reduce the injury to the ovary, especially by saving that part of the hilum. It's a problem of laparoscopic surgery. When you do cystectomy, you just pull it, then you always hilum area, then the hilum area will be bleeding, then you can reduce it. And then 2 or 3 step approaches endometrioma. It's a younger, remember, 1 minute only. So 1 minute, your endometrium is very big. So if you cannot do anything, just drain it. After drainage, then draining the endometrius, cyst, the cyst cavity, it just take a biopsy and keep her under GLRH analog for 3 months. And when the cyst will be very thin, the injury to the cortex will be less. After 3 months, as you can do the cystectomy. That's a common procedure. So laser ablation we are not doing. Last slide, that fertility preservation is very, very important at this age. So we think about the ovarian transposition, not accepted by everybody. Oocyte embryo cryopreservation, not everybody in our country, but somebody can do that. Ovarian tissue cryopreservation can be done. And ovarian suppression by GLRH analog, I don't know, but is now not accepted. So when you are treating a patient with any kind of surgery, if you just put the ovary in dormant step by giving generation, especially when you are giving radiotherapy or even chemotherapy. The patient is kept under generation for 3 or 4 months, and then from during that time, the damage to the ovary is said to be less. But this is not now accepted. But practically, we are doing it. So that last condition, in one patient, I got, edematous ovary, and there is a torsion. I did something that, operectomy. I sent that tissue for biopsy, and biopsy came as a normal ovarian tissue. So I was perplexed. Then I searched for the literature. During literature search, I got that there are some rare conditions where there is an edema of the ovary. That edema of the ovary because of intermittent some torsion. And it's not knowing that this is just an edematous ovary, if you are doing some operectomy in that particular patient, that patient is losing the ovary. So one should be very careful to do that. So you just give an incision, and there should be provision for what do you call it, frozen section biopsy. Of course, in our medical college, if you call people, they do it. And if you have got a 1 hour time, at least you can save your money. It is not to be removed.
Please, one minute, please.
That's the last slide. So make a habit of 2 things to help or at least to do no harm. Hippocrates, with this, we should approach this at the same level. Thank you very much.
Thank you, Dr. Bhuvan. You have very whole subject ready in short time, very nicely. So I think we can call the next speaker, Dr. Amal. He will speak on medical management of endometriosis.
As we are already running short of time and we have a virtual session to be starting at 12:15, with due permission from our chairperson, can we take only Dr. Amal Phukan sir's presentation and then thereby we stop to say?
That's okay. We'll see. After time, we can continue. I'll go fast. Whenever it comes, we'll interact.
Okay, however, we'd like to stop by 12 so that we can do the necessary connections for our virtual session. Okay. Again, I'd like to request Chairperson sir to kindly introduce Dr. Amal Phukan sir before he formally gives his presentation.
Dr. Amal Phukan is MBBS with honors, MD from JMCH, Senior Consultant Obstetrics and Gynecology in Jorhat, first General Secretary of Jorhat Society of Obstetrics and Gynecology Society, trained in laparoscopic surgery, Director at Sanjeevani Hospital, Jorhat, Assam. Now, Dr. Phukan, please.
Respected chairpersons, my teacher, sir, and my dear friends. As we are running short of time, actually this is a lateral entry for me. Actually, I was not supposed to talk today, but because one of the speakers is absent, that is why I'm going to talk on diagnosis and management of endometriosis. I will go a little fast because as we are running short of time. We'll go very briefly on this topic. As you can see, over 3/4, 75% more than, they experience menstrual cramps as adults, and 83% were told that the pain is normal. That means the misdiagnosis of endometriosis is very high. Almost pain seriously. Though they were complaining of pain, that pain was not taken seriously, and of a median delay of 8 years. You can imagine the progression of disease in this 8 years. This again, the earlier the symptom starts, the greater the delay to the diagnosis. Because if you see a pubertal girl coming at 16, 17 years with pain abdomen, we never diagnose her to be a case of endometriosis. So in that way, sometimes we misdiagnose endometriosis. A diagnostic delay for women with pelvic pain was 10.5 years and 9.8 years for patients with subfertility. You can imagine the amount of progression of the disease. And sometimes these misdiagnoses are as some come as psychosexual complaints, bleeding disorders, chronic pelvic pain, appendicitis, irritable colon, PID, etc. So these are some of the validated screening questionnaire for the presumptive diagnosis of endometriosis, and what are the how you do this with the model. These are some of the questionnaire we usually ask this leading questions because we want to exclude endometriosis in this category of people. Then these are the questions we should go for, and this is a simple. Because whenever a patient enters into the gynecological OPD, definitely we need to have a checklist or the thing in our mind. Actually, the mind, the eyes do not see what the mind doesn't know. So we have to have a feeling that the patient presenting with pain may have endometriosis. So this is a guideline of European Society S3, 2022. They have said that this we should consider endometriosis in individuals presenting with the following cyclic and non-cyclical signs and symptoms. As you all know, dysmenorrhea, big picture, and dysuria, dyschezia, painful rectal dysuria, all these things. On clinical examination, the vaginal examination, if it is appropriate, married woman presenting, you must do a vaginal examination, or in unmarried people, we can go for a rectal examination also to see deep nodules or endometrioma in presence suspected endometriosis, although the diagnostic accuracy is not very high, slow. In women with suspected endometriosis, further diagnosis steps, including imaging, should be considered. Clinicians are recommended to use imaging, ultrasound or MRI in the diagnostic workup for endometriosis, but they need to be aware that a negative finding does not exclude endometriosis. If the ultrasound or MRI say that this particular lady doesn't where empirical treatment was unsuccessful or inappropriate, so we can consider laparoscopy for the diagnosis and treatment of suspected endometriosis. So this is another algorithm, diagnostic algorithm, which the same thing. After the symptomatology, we can subject them for imaging, and if necessary, we can go laparoscopic diagnosis. But mind you that the negative imaging results doesn't rule out endometriosis. Even negative biopsy also doesn't rule out endometriosis. So this is the thing. We can see that diagnostic laparoscopy combined with, but whenever we go for diagnostic laparoscopy, not that we go in and go out, but if there is some associated pathology can be surgically corrected, it should be taken up in the same setting. We should do that. So what is there is a paradigm shift. Before this, there was a very much the shift was on the surgical side, but nowadays we take up surgery not as a first line, but initially we go for the medical treatment. So medical hormonal treatment. This is a yes. So we have got this we have got these three things. The hormonal contraceptives. One is common hormonal contraceptives. One is progesterone only contraceptive. Result in statistically significant reduction in baseline of endometriosis related pain, resulting in improvement in the quality of life. And two preparation, as we all know, estradiol and norethistran inanthate, and also ethinyl estradiol and osprenol. These are being studied. And also the POC, as you know, LNG-IUS, we use popularly known as Mirena. This is also being used for medical management of endometriosis. But the question is that what medical treatment we like to give? Is it an oral contraceptive, or is it dinogestin alone, or we will use both dinogest with ethinyl estradiol? So you can see the graph. During a normal ovulatory cycle, the circulating levels of E2 fluctuates between 13 picogram to 140 picogram. But if we give only dinogest, we can see that the level is around 3260, but it's quite stable. But I think there is one slide, the number 4 slide. I think we should know it that when we give an oral contraceptive, that means when ethinyl estradiol is given along with, then you can see that it's associated with the daily peaks in the synthetic estrogen component and possible daily stimulation of endometriotic lesions. So there may be daily stimulation of endometriotic lesions. So this is one important aspect. Both the ENG significantly reduce endometriosis related pain, dysmenorrhea, chronic pelvic pain for up to 24 months after device placement. So these are important medical management. So this is one molecule which has been ruling the scene now is a Dynages 2 milligram tablets. Then we can see that what are the inclusion criteria in this particular double-blind study is the woman aged 18 to 45 years with endometriosis-associated pelvic pain, histologically proven endometriosis stages 1 to 4, and minimum VAS 30 mm at baseline. This VAS is visual analog scale. It is the scale to determine the amount of pain. So 30 mm is the borderline. Beyond that is a weeks of treatment with VAS scale. That is visual analog scale. We can see that the graph is coming down to 30 and even below that, and it's quite sustained. And even after the treatment, we can see even after the treatment is stopped after 65 months, we can see this is continuing. Cumulative increase in the efficacy of Dynages over 52 weeks. So this is important thing. Then what is the guideline? There is a S3 guideline of 2022 that it is recommended to prescribe women a combined hormonal contraceptive, oral, vaginal ring, or transdermal to reduce endometriosis, dysmenorrhea, and non-menstrual pain. Women suffering from the endometriosis-associated dysmenorrhea can be offered the continuous use of a combined hormonal contraceptive pill. Actually, we are now more using this continuous 84 days tablets. It is also recommended to prescribe women progestogens to reduce endometriosis-associated pain. GTZ recommends the clinician to take different side effect profiles of progestogens into account. It is recommended to prescribe women and levonorgestrel ING IUS or an ENG subdermal implant to reduce the endometriosis-associated pain. GnRH agonist, of course, it was initially popular. Nowadays, it has come to the second position. It is recommended to prescribe women GnRH agonist to reduce endometriosis pain, although the evidence is limited regarding. DDD recommended the GnRH agonist to prescribe a second line profiles. And if we use at all use agonist, then you have to give a hormonal edbeg therapy, because if you use only GnRH agonist, that may cause bone loss and hypoestrogens symptoms. This is also with same thing. This is GnRH antagonist, as you know, that this also can be used the same thing. And then this is an important slide. You can see that. So we have got 1, 2, 3, 4, 5 things we can use. One is combined hormonal antagonist, and the fifth is aromatase inhibitors. Now it is letrozole is also can be used. As you know, it's an anti-estrogen, and it also can be used as a second or third line of treatment. Then we can see as you go, the endometriosis recurrence is very frequent. We get a lot of patients with recurrence. So patient receiving Dynages after conservative surgery. Patient has undergone surgery. After that, there is some recurrence. So we can use Dynages. It seems to be promising. So guideline prevention of recurrence. So suppose we have done a surgery, a beautiful surgery has been done by Dr. Manoj Majumdar, but even then we have to go for a prevention of recurrence. So we can use, when surgery is indicated at an endometrioma, we can perform ovarian cystectomy instead of drainage. And we'll go. I think Manoj will go talk about all these things. But definitely for prevention of recurrence, we can use an LNG IUS. Very easy. After these things, we can put a prevention of endometriosis. The clinicians can also perform ART, assisted reproductive techniques in women with deep endometriosis, as it doesn't seem to increase endometriosis per recurrence per se. Any hormone treatment also can be given to alleviate pain. Post-surgical management of deep infiltrating endometriosis. I think my friend Manoj will talk on post-surgical about this deep infiltrating endometriosis. And as we have talked about this, there is a paradigm shift in the endometriosis diagnosis, the questioning, and listen to your patients. He is telling you the diagnosis. So in endometriosis, we have got these phenotypes. Important phenotypes are superficial peritoneal lesions, endometriomas, then DIE, endometriosis, and adenomyosis. These are important endometriosis phenotypes. And moving from a histological to a clinical definition opens the door to an approach that emphasizes symptoms for their origin. Disease progression and postoperative recurrence. Again, we can see the patients with initial superficial lesions and endometriosis progress to more severe subtypes at recurrence. That is why this is the importance is that after the surgery, we should give proper medical therapy to prevent development of recurrence. This is again then bowel endometriosis and the role of hormone therapy. The bowel endometriosis, there we can see that we can give again diagnosis we have in our hand that is popularly being used and to reduce the symptoms of women with rectosigmoid endometriosis at the end of 36 months. And diagnosis demonstrated significant reduction in intestinal symptoms, constipation, diarrhea with rectosigmoid endometriosis. These are the scores you can see. Graphs I quickly go on. Diagnosis has demonstrated a progressive increase in the gastrointestinal quality of life, GIQ, LI, quality of life scores in women with rectosigmoid endometriosis. But of course, that needs a very longer duration of therapy. This is also another thing. This is a few things I like to add. Bowel endometriosis, we can have at the rectosigmoid junction, we can have it in the endometriosis of the proximal sigmoid, rectovaginal endometriosis. But in case of proximal sigmoid, endometriosis is proximal sigmoid, I think excision should be preferred. But other two conditions we can try with the medical therapy. This is, I think, Dr. Manoj Mazumdar will talk in a better way. Reduce incidence of recurrence with this medical therapy. This is an important thing. This is a evidence level A. Evidence level of A is clinicians are recommended to use progestogens, medroxyprogesterone acetate, dinostate or cyproterone acetate, or noracistone acetate, or denadiol, or antiprogestogens. One of the options to reduce endometrial associated pain. This is level A. That means we can definitely go for this. Then this second thing they are talking about. Just 1 minute. Clinicians for prescribing this LNG IUS is B. This is stage 4, stage 5, dysmenorrhea. I'll quickly go through because time is short. And diagnosis leads to statistical significant reduction in endometrium. Whenever we see an ovarian endometrium on an ultrasound, doesn't necessarily mean that immediately we jump on the patient to do a laparoscopic surgery. Definitely less than 3-4 centimeters, we can definitely try for medical management. It definitely reduces the endometrium, the diameter of the endometrium. Pain relief is also there. In Asian population, just remember one important slide. In Asian population, very prolonged use for 3 years is associated with BMD loss. So we have to take appropriate counseling for that. This is showing a take-home points. A Cochrane review on combined oral hormonal contraceptives for pain associated with endometriosis highlights the lack of reliable evidence on its potential benefits and harms. Patient preference, circumstances, and values should help inform the selection of the appropriate treatment. That means all patients and all treatments has to be individually tailored. All are different. Patients often consider hormone therapy ahead of surgery, given the complex and potentially life-changing complications that can, on rare occasions, be associated with surgery. Thank you. Thank you.
Thank you, Dr. Rama, for dealing with this subject extensively. So I think we should go over discussion because actually we have a session afterwards at 12:15. So for that we need some preparation. During that preparation time, we will go for discussion. Any question from the audience for these two speakers? Then just after the virtual session, we will continue our discussion. There are another two very important topics. One will be dealt by Dr. Manoj Mazumdar, who will be dealing with deep infiltrating endometriosis, and Dr. Sankadas will be telling about endometrial fluid before embryoplasty. So these topics will go for, just after we will complete the discussion now. Now please ask any question from the audience. For last two speakers, Dr. Bhupan and Amal Bhupan and Dr. Palaj Bhupan. এই মজুমদাৰ আপোনাৰ অলপ পিছত হ'ব আমি তাৰমানে এই চেশ্যনৰ কাৰণে প্লেয়াৰ কৰিছোঁ অ'কে এনি কুৱেশ্যন প্লিজ So after this interaction, we will have a very important session by Dr. Pankaj Desai. So he will be offline and he will be speaking on vasculopathy in preeclampsia. So we are preparing for that session. That will be an online session. So you are not offline, so it will be an online session. So we will be speaking on vasculopathy in preeclampsia. So after this session, we will be continuing with Dr. Manoj Madhukar and Dr. Shankar Das.
Good morning, sir. So I have a question to Dr. Ponnakopan, sir. He is saying last few cases he is doing just untwisting. My question is the overall arm because untwisting. So thing is that when I'm twisting, whether he remove the cyst or not, very rarely goes twisting. So whether we remove the disease part or not, at the same sitting or not. So that's my question.
Very good question, of course. I did get that. I will delete it. Normally, initially I told that the 50% of the torsion of the adolescent pelvic lump is benign, absolutely benign, in a simple cyst. So you're not scared about that. But when the patient is having risk, 50% is the ovarian cyst. What we do, we do detorsion and then do cystectomy. But we don't remove the ovary. We do cystectomy in most of the cases, last 4-5 cases I remember, people do. And then we do cystectomy and the patient is kept like that. But during cystectomy, you also be careful to handle that tissue very carefully so that you are not injuring it. First, you do detorsion. Wait for 10 to 15 minutes. After that, there will be blood flow starts, and then you can do the cystole. During the cystectomy, you should put some vasopressin so that tissue is not much damaged. You can get the cleavage. It is not difficult at all. So cystectomy can be done in those cases.
Good morning. I am just sharing my experience with Dr. Ponnakopan sir. So even I used to get cases with ovarian torsion, which definitely there is a ovarian pathology, but after untwisting, the blood flow begins to regain it, and then you can do the cystectomy as usual, and ovary will be all right. That is my experience. That's I am sharing.
So it is really very not difficult. It's really easy. The stories like that, I didn't know about this. About couple of years back, one of my postgraduates came to my table and then she has told me, sir, this is not that thing that we are doing. She has gone for the Williams gynecology and she has opened the book and she has showed me around 7 years back. Sir, this is the procedure we should do. And from that time onwards, I am doing it. So the postgraduate students sometimes teaches us. Most of the times, I am a very lazy man. I don't read. I just ask them to read and they come and they read it to me and I do like that. So that's how we are benefited from the postgraduate students of my unit.
Thank you. So I have one question. So say the patient is an adolescent patient and coming to lump, and you have a suspicion that it may be a malignancy. Say sometimes there are borderline malignancy. So in that case, how do you manage? Regarding projection or ultimately management, what will you do?
Yes, sir. The clinical suspicion is very important. That's why I told that IOTA should be practiced very carefully. So if you have a suspicion, you just ask the sonologist to go for aorta. If 1M, okay, you can't leave the ovary like that. You have to go for operectomy. 1B, no problem. B and M is the main problem. Both M and B is combined in iota. In those cases, you can take help of core-needle biopsy, which is done by some of the radiologist person in our medical college, which can just send the patient to core-needle biopsy. Core-needle biopsy give 95% sensitive result. So you can do the core-needle biopsy, and if you find that this is a case of malignant tumor, definitely you have to go according to the staging. The stage 1 disease, just operectomy. But you have to search everything. All the process of, steps of the surgery for staging that should be done, including the collection of the peritoneal fluid, ascitic fluid, palpation of the omentum, liver, everything should be done.
Thank you. So another question, say, what about the laparoscopy? What precaution you will take regarding malignancy?
Malignant ovarian tumor, the laparoscopic surgery is controversial because the chance of this, this tissue can go to the cavity is very high. So if you can do in-back, inoculation of the ovarian tumor, it is stage 1 disease. It is recommended that you can do that. Stage 2, stage 3 disease, better you go for laparotomy with all the precautions, like staging laparotomy. So the operations are same in adolescent, it's a stage, late stage disease. But when they stage 1 or stage 2, because many women, young girls, they come early. It is not like adult women. They come early and diagnosis in most of the cases. Ovarian tumor, that's the difference. In adolescent people, they come early, but adult people, they come late.
Thank you. Any more question? Regarding endometriosis, any question, any doubt, or any suggestion, comment from anybody?
As our moderator sir, asking for more questions on endometriosis, I cannot sit up there. Endometriosis is a disease which is very close to my heart, and it creates a lot of pain to our women society. And I usually got cases in advanced stages, recurrent cases, and in a very difficult cases that I mean. So, as already Dr. Bhupan has said, it for every woman, the treatment of endometriosis should be tailored. Tailored means according to the age, requirement, problem, it should be tailored. Otherwise, now the dictum is surgery is not the only answer for treatment of endometriosis. When we treat endometriosis with surgery, our aim should be that ladies should be subjected to only once in her lifetime for surgery. So surgery, if it is only required, it should be done only once in her lifetime, and it should be a optimum surgery so that she should be benefited for rest of her life. Thank you.
Hello. Hello.
ইয়াৰ পাছত জুম মিটিং এখন হ'ব এইটো কাৰণে টাইমটো মিলাবলগীয়া হ'ল এতিয়া এইটো মই কেতিয়াবা টাইমটো নিমিলিব সেইকাৰণেতো বন্ধ কৰি মিলাই আছে
পাঁচটালৈকে আছে নটা বজাতে জুম মিটিং নটা 40 লাগে কোনো মানুহে পঢ়ে আকৌ বনাই আকৌ বজাব আছে এইখন যদি নহয় নহ'ব চাৰিটা আমি আছিলে আৰু এটা হল আছে 3 নম্বৰ হ'ল 3 নম্বৰ সেইটো চলতে আছে প্ৰথমত চান্তানে কি
ঠিক 12:50 আৰম্ভ হৈ যাব। যেতিয়া অডিয়েন্সলৈ ঘূৰাব তেতিয়া অডিয়েন্সলৈ
Classroom.
Okay, we are ready. Yeah. Oh, okay. So I think we are ready. Okay. उसको वापस रखूँ बेटा।
NEOGSCON to lagi itu kalau betul lah mana?
So now we'll be going for the next session, which will be partial session. So our eminent teacher, Dr. Mohammed Desai, is an eminent gynecology, as well as a great teacher of obstetrics and gynecology. And he will be delivering a speech on vasculopathy in preeclampsia. He is speaking from Baroda. So within few minutes, we're going to connect with him.
I am happy to announce that he visited us. He attended our last NEOGSCON here in Jorhat in 2008. At that time, I think he was the president.
Namaste. Namaste. So happy to see you. You are a legend, and you are also talking in the session, in whose name the session is there. He is a legend. You have met him when you came to Guwahati. So we look forward to you. lecture.
Sir, can you hear us? Sir, we are audible to you. Desai sir.
Hello, good afternoon, sir. Are we audible to you, sir? Good afternoon, hi, sir. Are we audible to you, sir? Good afternoon, Desai, sir. Are we audible to you, sir?
Hello.
I can see from the. Yeah. Dada, I can't hear you.
Good afternoon, sir. Are we audible to you? Good afternoon, Desai, sir. Are we audible to you, sir?
I can start. Yes, sir. Sir, you are audible to us. Please start your speech. Yeah, okay. I can't hear you, but it is okay, no?
Yes,
Please. Now, okay. Kanda, it's a message the most disabled participants sharing. Please help me so that I can put my slides on. Most disabled participants screen sharing. Okay. So, please, we are doing it. Yes. Thank you. Yes, sir.
Good afternoon, sir.
I can hear you, but the message is most as disabled participants sharing.
Yes, I hear from our end, it's done, right? But I don't know why you are not being able to share your screen.
Yes. Please try now. Please try now, everyone. Please try now again. Who's disabled? Please start. You are very good now. Yes, yes, we can. Yes, please start.
Hello, hello, hello.
Yes. Yes, sir. Hello, sir. Hello. Hello. Hello, ma'am. Hello, sir. Hello, sir. Can you hear us? Hello. Please, sir. I can see you only. Oh yeah, I can see you only. Okay, you are audible. You are audible now. Okay. Okay. That's 1 minute, sir. We are trying again. I hope you can hear me. Yes, yes, I can hear you. My friends, I hope you can hear me. My dear friends are joining the session. Yes, I can see Apurva, I can see Saraswati. Okay, Saraswati, can you see the screen? Yes, sir. Shake nod your head.
Screen.
Yes, sir.
Yes,
we can see. Okay, I will start. As usual, we will start with a prayer. When we pray for harmony, because the harvest the countries are existing harmony, and all people enjoy happiness. Honorable Dr. Pranamita, Dr. Apurva, very dear Dr. Kokuda, Dr. Arun Barwa, Dr. Ratna Kankan, Dr. Amal Gupta, Dr. Hemkan Sharma, Dr. Saraswati Chaudhary, Dr. Kokuda. Thank you very much for this honor. I am now taking you to the enigmatic world. Enigmatic world where you are going to change your thinking. And I will be going in these 30 minutes from our traditional thinking to modern thinking to futuristic thinking. And I will take exactly 30 minutes. I plead for your complete focus because the topic is difficult. The topic is obstetric vasculopathy's latest concept, or that have a placental vascular origin are called obstetric vasculopathies. Interestingly, all have an immunological basis. And what all it includes? It includes preeclampsia less than 32 weeks, recurrent fixed abortion of the first trimester or the second trimester, recurrent stillbirth, IUGR of placental origin, and accidental hemorrhage. Sir, just disconnected for some time. Again, we are connected. You are connected. Yeah, yeah.
Can you hear me?
Yeah, yeah.
Can you see my slide?
Yes, 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 yes.
Can you see my slide? Okay. Can you hear me in the hall?
Yes.
We can hear you.
Okay. Why do actually vasculopathy is there is incomplete incompetent presentation. The failure of second layer of vasculation. So the placenta is at fault. There are viral ideals and uninterrupted spaces that become mechanism function, leading to an array of statistical activities in the subendothelial matrix and interstellar spaces. As a result of this, the LDL and VLDL sits between the two cells, and this is where the reactive oxygen is. And they denature the LDL and VLDL. Now, when the vasospasm gets released, the free oxygen radicals which have denatured the lipids, they will swarm the maternal vasculature, and wherever these denatured lipids will go, there will be a vasospasm. You can see this on the slide here, that wherever the vasospasm is relieved, the HDL and LDL will go. So the LDL and VLDL which are peroxidates go and produce a vasospasm. This is when the mother senses that the blood supply is not enough because of vasospasm or this is a blood pressure, and you call it as pre-eclampsia. Come to the second part, because the current thinking where the fault is with the placenta. We come to the second part, and that is prediction. There are two sets of current thinking in prediction is to do two sets. One is blood, and the other is chemical biomarker. The problem with biomarkers for areas like Northeast in particular, and entire India in should I continue or can you answer the teacher?
I can hear you.
I say.
Yeah, yeah, yeah. Yes.
I say.
Can you see the slide? The problem with chemical biomarkers is it is time consuming, needs extra visit to the laboratory, and the patient pays extra to our resources. We want something which is cheap, easily available, and reliable, and simple. At least where your color doctor will help you. PI more than 1.7 is used to predict pre-eclampsia in many papers. We also studied it, and we found in a prospective study that 1.7 or more PI at 11 to 14 is significantly able to predict pre-eclampsia. Very accurately negative predictive value means if it is less than 1.7, the chances of pre-eclampsia are less. But still its specificity was quite good and high accuracy. This is one part. We come to the second part, and that is diastolic notch. We have studied diastolic notch, and we just see here, this is the diastolic notch. Those who are doing doctors like Apurva and all know. But it is a common phenomenon, must be seen at 11 to 14 weeks in the uterine. Now see this diastolic notch, and see this diastolic notch. The depth of both of them are different. Also, that means it is telling you something. So what we did we measured this diastolic notch, and we found that the notch depth index of this notch, which I showed you earlier, was 0.37. And then of this notch is 0.12. Now, both don't give the same results. It's that there is some problem with it. 0.37, or suppose it is still deeper, goes down to 0.5, then what happens with these cases? Because we want to examine the evidence, and we found in 297 prospective followed up, there are significant number developed vasculopathy in preeclampsia. If the NDI was 0.5 alone, not clubbed with 1.7 uterine artery PI. Now, the specificity was very high, 87.1, and a very high accuracy. When we combine 0.5 NDI with 1.7, there were separate 264 cases, and we found that there was a very high accuracy and a nice specificity and a statistically significant value. So I am giving you a new technique. The biomarkers fit uterine artery without doing biomarkers. We are in our setup, and many parts now in the country are able to predict preeclampsia satisfactorily. And this is not something which I have been speaking alone. Incorporate the reports of the doctor. It is very nice, more than 1.7 alone, or if PI is more than 1.7 and NDI is more than 0.5, that's great. But it's one further. And what? I'm repeating. If we are more than 1.7, NDI more than 0.5, both are very different. But suppose we first, we found that if PI is less than 1, that's a very problem. Diastolic notch, the population is very confident to tell you that this is a low risk subject, don't worry. If you have started aspirin, stop. We now come to the next finding. That in second trimester, a 20-week scan, their approval is very confident in picking up malformations. If you find diastolic notch persist, it should by this time. This is a high risk subject. Continue preventive measures which you already started, don't stop them. But starting aspirin at this stage will not help if you are not yet started. Okay, academic-minded people like Shashwati or Gopalda or Himal, the API alone is more than 0.4. All also is very confident when we start aspirin. Ladies and gentlemen, in our setup, we have been able to reduce the incidence of preeclampsia by 16 times. So it has come down to 1/6 of what it was originally. This policy being followed for last nearly 10 years. We come to the last part of the lecture. And I am introducing you a future. First, second is prediction, new things, and a novel thinking. Started raised by St. George's University Group in London, but many of us are already in this for quite some time. And that is, there is a novel thinking now that in preeclampsia which will completely change the outcome. I know that many questions in the past period, the placenta was at point, it may not answer. So there was a dilemma. A new theory has come, and the focus has shifted. Placenta to the heart or the cardiovascular system. As per this theory, preeclampsia occurs due to problem with mother's cardiovascular system. In our mother's cardiovascular function is compromised even before pregnancy, and pregnancy adds to a heavy load, resulting in a series of adverse malformations. So in a mother with suboptimal cardiovascular problem, her circulation is compromised already, and there is inadequate perfusion of her body. This inadequate perfusion is also at the level of the placenta, and so the placenta suffers. So the placenta is not the villain, but a victim, and therefore it brings about all the changes which I have shown you in the first part of the lecture. You are all science students. You want proof, and I will give you the proof. Significant cardiac dysfunction, both before and at critical onset of preeclampsia, function is compromised. So please wait. This author has shown that preeclampsia subjects are associated with abnormal cardiac geometry and diastolic dysfunction. Even at pregnancy or early in pregnancy. That means her cardiovascular function is already compromised. And this third study has shown that in people who develop preeclampsia remote from term, they have a significantly lower cardiac output. So even before the pregnancy, the geometry is compromised, the cardiac output is compromised, and our cardiac functions are, but the contractile function is compromised, and the pregnancy is inserted over it. Then the entire placental system goes haywire. You have all seen one clinical observation, but which you did not have an answer. And what was that? In subjects, even if cardiovascular function is not altered, when the demand is more, preeclampsia occurs. pregnancy, in in post-pregnancy, diabetes, in excessive weight gain, all of these, preeclampsia occurs not because of the placenta vascular, but because mother's cardiovascular system is now compromised because the demand is poor. This lecture is available on YouTube in case you are not able to hear or see. My channel is there. I have put the name here and you can see it there. Now let me show you one more proof, one very interesting observation. In one study it was found that on an average, the pregnant mother left ventricular mass increases by 40% in about 9 months. Now, when this was compared with the increase in the left ventricular mass of more alarming, it was found that once they start coaching full-on airplanes, they register around 25% increase in left ventricular mass over a long period of 24 months. Now, we are giving these mothers only 9 months. She is expected to boost her ventricular mass by 40%. Now, my friends, if her system is already compromised, then she might be able to bring about these changes effectively. Her placenta and her entire maternal cardiovascular system is hard, and she will develop a preeclampsia. Now I will tell you one very interesting phenomenon which you have observed in clinical practice. If once pregnancy goes, the effect, that is the preeclampsia, should also disappear. Does this really happen? This was the cure to preeclampsia. Not always delivery permanently takes care of the process of preeclampsia. Hypertension persists long after pregnancy or typically because the mother is already having a compromised function. That takes time to reverse, and you see her hypertensive even 6 to 9 months well after her pregnancy. Obstetricians will require new tools to predict it. I will tell you. And those tools will have a cardiovascular system of basis. It should be able to measure cardiac output and systemic vascular resistance. If a mother at pregnancy or at any stage of pregnancy is low, then your systemic vascular resistance high. Within 2 weeks, you will develop preeclampsia. This is prediction. Whenever your cardiac output is normal, then systemic vascular stomach. Patients should be aware that cardiovascular disease of preeclampsia must be compromised. It will soon be wise to measure cardiac outputs or cardiac function assessment in early pregnancy. Be prepared. Pre-pregnancy care. It will need specific tools to identify compromised cardiovascular. It can be a scientific way to select pregnancy. Pre-eclamptic mothers who show persistent hypertension after the pregnancy, long deep in the field failure, or even the after that, should be investigated for affected cardiovascular problem. So there are cases where compromised, pick them up. There will be cases cardiovascular function not compromised. Then after pregnancy, blood pressure will be right by 70 normal. Forget about that. But now your approach should be more scientific and less empirical. Friends, I know I have mentioned a lot. I have very few things, but that is what I have been doing always. This must be by 28th or 29th lecture the Lord. And every time, because the audience here is very receptive, I try to do latest things. And I work very hard. I'm sorry I can't fly down there but I have tried my level best to put in latest things for you. Then today, pre-eclampsia and obstetric vasculopathies are changing so fast. Same place. What was normal today is probably obsolete tomorrow. So be prepared. There are lots of mysteries to solve in the times to come. This is one mystery I have solved for you today. Be prepared for the service of humanity and mankind. Solve many more mysteries in the times to follow in obstetric vasculopathies in general and pre-eclampsia in particular. Ladies and gentlemen, I don't know how much you could hear, but this lecture will be available on the channel of mine. Thank you.
Thank you, sir, for an excellent speech. Hello, sir, can you hear us? Am I audible to you? Hello, sir. Yes, thank you very much, sir. Thank you very much. I think, I will email. I have the email. Thank you very much. We are very grateful to you. Everybody else. So, I think you have listened a legend, and it is an excellent lecture on osteopathy and preeclampsia. If there is any question, you are asked to email him and you will answer. We will continue with the other part of our session. Now, our next speaker is Dr. Manoj Kumar Majumdar. He will speak on deep infiltrating endometriosis. Dr. Majumdar, please. Dr. Manoj Majumdar is an associate professor of Guwahati Medical College in Obstetrics and Gynecology Department, and he is the faculty's state and national conferences, life member of POXI, life member of IIG, life member of Society of Fetal Medicine, And areas of interest is to make the medical college a laparoscopic training hub. So he is doing it in JMCH.
Hello.
So Dr. Mulkan.
Thank you, Chairperson. Thank you, respected guests, my seniors, my colleagues, and my juniors, for giving the opportunity to say in a beautiful, organized scene. So my topic is deep infiltrating endometriosis. Mind does not know, we cannot see. In my student days, still I remember, we get a very limited amount of theoretical knowledge of endometriosis. We don't have any exposure of endometriosis on those days. So in 2000, when I was in laparoscopic training with my guru, Dr. P.G. Polsar, I saw lots of endometriosis and chocolate on those days training period. And one day he asked me for the incidence of chocolate cyst or endometriosis in our place. On that day, I probably said, no, sir, we don't have any endometriosis in our region. I have not seen anything. But that's the scenario in 2000. After that, I'm coming to my hometown and I'm practicing endometriosis. I got very frequently some superficial endometriosis that I diagnosed. And after that, this goes on. And 2 years back, 2017, 18, I got an ultrasound report from one of my most respected, knowledgeable radiologists in Guwahati. And he wrote a comment, the eye is not seen. So till then, to be honest, I don't have any knowledge of the eye. Then I immediately searched the net and the books. I saw the eye means deep including endometriosis, and I asked him over phone, that what is this? Then he explained the things that they were not. I am searching for the eye everywhere. And from that, they are not also when I'm doing some laparoscope or when I do attend some CME or workshop, then my knowledge is going on. And today, any workshop without a deep illustrating endometriosis is incomplete. So that is just I'm saying, because there are knowledge, background knowledge, theoretical knowledge, and our diagnostic tools are now available freely. So that the eye also increasing very rapidly. Then what is DIE? The endometriosis is inflammatory chronic disease characterized by presence of functioning endometrial tissue, both gland and stomach, outside the uterine cavity, causing pain and many a time for this. DIE is an infiltrating form of endometriosis with most aggressive presentation, penetrating more than 5 millimeters under the perineal surface. Some DI define as endometriosis externa, which unique lesions, frequently 2 or 3, that are large, more than 1 centimeter. And the recent Cochrane meta-analysis, DI is also defined as the infiltration of the fibrous and muscular tissues in organ and anatomic structure affected by endometriosis, including endometrial tissue, which no reference to depth under the peritoneum. It is a multifocal disease, primarily affecting the posterior area of the uterus and frequently involves the uterine ligaments, the thorax uterine, as well as posterior vaginal and enterorectal organs. Furthermore, the bladder and urinary systems may also be affected. The incidence, the exact prevalence of the endometriosis is difficult to mention because many of the pathologies are asymptomatic, so the patient didn't report. There's a lot of the statistics, 7 to 8% of with 50% of women with infertility endometriosis. This including endometriosis affecting nearly 20% of women who are suffering from endometriosis. Isolated DIE is around 6.5% in absence of other types of endometriosis.
What an organ involved in DI? It basically involves the posterior compartment, the uterosacral ligament, rectovaginal septum, rectum, rectosigmoid colon, and the bladder and the ureter. The lesion called adhesion and scarring cause complete distortion of the pelvic anatomy. Can be in pelvis and rectal examination and can be nodules. But the etiopathogenesis, how it develops. The Simpson theory of retrograde menstrual flow that is not very much suitable for developing that DIE because 90% of ladies observe there is high amount of retrograde menstrual flow, out of that only 10% is endometriosis. The same cell or progenitor cell may play a role in the origin of premenstrual endometriosis. Another hypothesis suggests that endometriosis cell undergoes tumor-like genetic and epigenetic modification, and these changes influence the progression of DIE. The onset of DIE in adulthood indicates that DIE could be a retrograde stage of endometriosis. That's an immunological aspect. DIE characterized by higher expression of invasive mechanisms caused by nerve growth factor, vascular endothelial growth factor like this, compared with the superficial and ovarian endometriosis. The classification of DIE. Two more classification of DIE. According to Knox and Martin, there are three types of DIE. DIE 1, type 1, large lesion in perineal cavity, infiltrating conically to the deeper parts, becoming progressively smaller. Type 2, bowel is detected over the lesion, which become deeply situated in the rectovaginal septum, not already infiltrating it. Type 3, deepest and most severe. The spherical and situated deep in the rectovaginal septum. The another classification Conrad and Nosle is true DIE and pseudo DIE. What is true DIE? The invasion of a very active perineal lesion deep in the retroperineal space. In case of lateral perineal invasion, uterosacral ligament can be involved as well as anterior wall of the rectosigmoid bowel junction. That result in retraction, adhesion, and secondary oblication in cul-de-sac. Pseudo-DIE is also known as adenomyosis of rectovaginal septum, consisting of essential and smooth muscles with active granular epithelium and scanty flow. What are symptoms representing which? The symptoms are various. Mainly, the main symptoms is pain. The pains, the deep dyspareunia when it involves the rectosigmoid pouch and uterine ligament in the cervix. There is dysmenorrhea, secondary dysmenorrhea which start 1 to 2 days before menstruation, and dysphagia when it involves the rectum and rectosigmoid. And chronic pelvic pain, sometimes dysuria when it involves the bladder, sciatica due to the involvement of sciatic nerves, and some patients present with infertility. And menstrual symptoms. Menstrual symptoms vary from scanty flow to heavy flow, is very unpredictable. Then urinary symptoms that are more common with bladder involvement. Urinary symptom will persist despite of negative culture report. Rectosigmoid GI symptoms, where it involves the rectum or rectosigmoid thing, the luminal constriction causing constipation, rectal tenesmus, dysphagia, hematochezia, diarrhea, and colicky abdominal pain. And what are complications of DI? It may cause frozen pelvis, intestinal obstruction, hydronephrosis, hydroureter, and spontaneous hemorrhage in the perineal cavity. How would we diagnose DI? To diagnose DI, the basic background knowledge, suspicion is utmost important. The history is very much important, and along with this, we have some laboratory tests. We are doing some C125, but nowadays the C125 is not much recommended. And imaging, ultrasound seems to be the very important tool to diagnose DI. Nowadays,
The machines are very much good, resolution is excellently good, and of course, the operator also should be skilled enough to diagnose DIE in transvaginal ultrasound. So it is considered as a gold standard for diagnosis DIE. And my experience, I told you, I had the exposure, past exposure from a report of a good sonologist in Guwahati. Then CT, yes, we can have some CT findings too when we have some suspicion. MRI is a very added advantage many a time. So it gives a good clue, good diagnosis for diagnosing DIE. And endorectal sonography, yes, many of the time, especially in very much young adult, when coming with a suspicion of DI, you can go for endorectal sonography. Then sometimes when you're suspecting some obstruction, then barium can be done, barium enema can be done. Next, sigmoidoscopy. Yes, sigmoidoscopy, another tool when it involves to diagnose the involvement of the sigmoid column. Then cystoscopy when you suspect some bladder involvement. Then diagnostic laparoscopy. It's a gold standard for diagnosis of DIE. It can help identifying the following lesions: the endometric nodules or lesions having blue, black, or powder bar appearance. That is the gold standard when on the teaching, it is very clearly written in the books, a powder bar appearance. But many of the time, that thing is not even so. Lesions may also be red, white, or non-pigmented. Yellow, brown, or brown, blue, or black discolorations of the endometric tissues in proportional to the amount of hemocyanin deposits. Laparoscopy can also detect the presence of blood in POD or endometrial deposits in cul-de-sac and its obliteration. At the time of laparoscopy, ovary must be carefully mobilized to inspect the anterior surface for the presence of adhesion, which is strongly suggestive of endometriosis. Biopsy, yes, sometimes we can do for biopsy, but again, biopsy is not always proved to be case of DI of endometriosis. And when I think of treatment part, that Omolda very clearly highlighting the medical part, so things become easy for me. So I'm not going for details in the medical management of endometriosis. So when you think of the management part, we should take patient age, patient history, patient past history, disease stage, symptoms, severity symptoms, pregnancy, that means pregnancy, desire or fertility, personal choice, these should be considered. Then medical treatment has proved to be useful in both stopping the growth of the lesion and including their regression, which consequent improvement of the symptoms. Pharmacotherapy, the agents include used the oxypyl, orate estrogen, androgen, GNH agonist or antagonist, and aromatase inhibitor. These are the things we can treat as medical therapy. And adjuvant therapy, many of the times we can be tricyclic antidepressants such as amitriptyline may be used. And surgical management. Now, when you think of surgical management of endometriosis is based on the principle of surgical management of oncosurgery, because the radical eradication of the endometriosis by surgery. The second important point, the first surgery is the best approach for the treatment of endometriosis. The goal is to complete eradication of the pathology and achievement of a good long-term outcome in terms of pain, relief of recurrence, while trying to respect the functionality of anatomy, and involved organs are also restoration of fertility. Most widely agreed primary treatment is for symptomatic DIE. Surgical treatment involves elimination of the endometrial lesions and interruption of nerve pathway for relief of the pain. Small peritoneal lesions less than 5 mm can be treated with laser or bipolar coagulation or applying constant irrigation. Laparoscopic uterine nerve ablation or laparoscopic presacral neurectomy is another procedure to give relief from the pain.
the surgery of the bowel, when it involves the bowel, what we do? There's something called shedding. That means superficial shedding of the bowel serosa or serosal endometriosis. Superficial excision, selective excision of the bowel ends and without opening the bowel lumen. Full thickness this excision. Selective excision of the bowel endometriosis, opening the bowel followed by closing of the bowel wall. Bowel resection and anastomosis. Resection of the bowel segment affected by endometriosis followed by anastomosis. Then bladder GI, many of the time bladder is involved. Depending on the involvement of the bladder, the following procedure can be done. Saving, cell thinning, and partial cystectomy, and transurethral resection. These are the things we can do when the bladder is involved. 1 minute, sir. Urethral GI. When urethral is involved, again the same thing, excision or some ureterolysis. Another take-home message. DI is considered the most aggressive form of endometriosis that can affect the whole pelvic, subverting the anatomy and function of the vital organs with a profound negative impact in the quality of life. Once diagnosis, medical treatment can be control symptoms and stop development of the disease, keeping in mind the side effect and recurrence once if hormonal treatment is failed or contraindication to the hormone therapy or the symptoms is very severe or some amount of obstructive pathology there. The conservative surgical approach by a multidisciplinary team is always preferred. Thank you, sir. Thank you very much.
Thank you, Dr. Mohammed, for a wonderful presentation. We'll keep the discussion after the next speaker. The next speaker is Dr. Jorhat. CMD of Jorhat and Research Center in Bongaigaon. He is a director of Swagat ERT Clinic, Bongaigaon. He is a senior gynecologist with over 25 years of experience in obstetrics and gynecology, specializing in IVF, laparoscopic surgeries, and ultrasonography. He has penned on more than 20 research papers. He was the organic secretary of NEOGSCON 2010. As the best president of the Mejaangkori in 2021, which I had the privilege of attending it, faculty in various national and international conferences, and he is an honorary professorship by IMA at Delhi on 5th September. Besides this, he has many other qualities. That means he writes very good songs, and he has penned on many nice music, and it's very nice to hear them. So I will now listen to the academic pointers and the material before I will transfer to Shankar please.
Good afternoon to all respected chairpersons, my teachers, seniors, engineer. I'm the last man. It's a big responsibility given to me to keep you awake. And let me appreciate the organizers for hosting such a beautiful conference, because I know I was the organizing secretary in NEOGSCON 2010 in Bongaigaon. That times I knew the pain and other things you passed through. Really appreciate your work. The topic I am giving foot and brow cancer. It is one of the difficult situations the ERT practitioners face. So, being an ordinary practitioner in the place like Bongaigaon, I always keep telling and I always stress two things. One is cost of the procedure. If there is some factor which has negative impact on the success rate in terms of pregnancy, it really makes us to worry. You also do so. So this is our procedure ERT. So regarding my topic, it's very small topic. I have only 20 slides. I will not take such time. Just relax. Why we are worried? Little bit I have said what to do. That's all. So you know the endometrial fluid consists of, it may be blood, it may be mucus, it may be endometrial secretions, mostly glycogen lack of molecule, and tubal fluid. Origin of the fluid may be hydrosulfates from overactive fluid generation due to the gonadotropin therapy that we do during ovulation inductions in the IVF procedure, and subclinical infections, and after HCG administered due to the reactions of the HCG. So, in fact, uterine cavity fluid, uterine cavity fluid, has negative impact on implantations. It is a normal thing happen. It is not visible on your sonography many times. Little bit of fluid, that's why it is not visible. Periovulatory fluid rich in glycogen and mucin, which provides nutrition to the loading embryo, is observed as a middle line of the trilemma on sonography. Unless the fluid is captured, the embryo cannot come in contact with the maternal endometrial surface. And the pinopods, which are nothing but the endometrial protrusion, they have the responsibility to absorb the fluid. So this is the morphological factors also very important. So this is a slide I have borrowed from Dr. B.N. Chakraborty sir's book. You see, when the implantation happens, it happens in different stages. Maybe appositions, adhesions, penetrations, and invasion. I remember like RP, there's a girl, RPI. So appositions, adhesions, penetration, and invasions. There are many other factors, maybe immunological, maybe molecular, maybe biochemical, maybe genetic expressions, which factors are responsible for these stages. In the appositions, many cytokines, chemokines, interleukin 8, like that, L-selectin, these are the immunological things happen, and it is secreted both by endometrium and the embryo. This is the thing. So this helps in the appositions. And second thing is these adhesions. Another very important factor which plays very key role, that is an integrin, both secreted by this endometrium and the embryo. It helps. It is a cell adhesions molecule. So it is responsible for the adhesions between the endometrium and your embryo. So, and when this your pinopods, I have said, this has a responsibility for absorptions of the physiological generated fluid that happens in the uterine cavity. So after that, if the embryo goes for penetration and invasions, the blastocysts are trophoblastic cells. It releases many proteolytic enzymes like matrix metalloproteinase, plasminogen activator. These are the things which help in burying your embryo on the endometrium. So after that, under the influence of the progesterone, where there is a vascularity angiogenesis, secretory, the whole endometrium transforms to that secretory phase. There's a glandular proliferations. This is a basic of your implantations mechanism. That's why I have touched it. So I have said the stages of embryo implantation, position, adhesions, penetrations, and invasions. Everything I have spoken. Progesterone is a very important hormone. You know all. This is a diagrammatic presentation of the pinopods. Healthy pinopods is very important for the successful implantations. So endometrial receptibility depends. Again, I have said, to summarize, it is a molecular factor, a morphological factor, the pinopods. Molecular factor, you can remember, integrin. Immunological factor, interleukin. And genomic expressions, HOXA10 and HOXA11. Genes are responsible. And you also know local factors can also hamper, like thyroid, polysomia, etc. And lastly, environmental factor, lifestyle, smoking, and systemic disease like thrombophilic disorder. And I stress two hormones are very important for the implantation, that is estrogen and progesterone. The incidence of the endometrial cavity fluid is around 3.8 to 8%. How much you people are getting, I don't know. But in my practice, it is around probably less than 3%. I will share two cases I dealt. It is a difficult situation. This is the one case where you have seen endometrial fluid. The AP diameter is 3.4 millimeter. Another case is a myoma with endometrial cavity fluid. So case one, I have two cases only. It's unexplained secondary infertility. Last childbirth 8 years. Husband oligoterospermia. IY was done 2 times failure. AMH, her AMH is 6.42 nanograms per ml. IVF plan, developed ovarian hyperstimulation syndrome, 8 oocytes retrieved, and 4 blastocytes formed, all are frozen. So rest is given to her because of ovarian syndrome. So after 2 months she came, no stimulation. I started 12 milligrams daily. Fluid is more than 3 millimeter in intercostal diameter in sonography. Endometrium stuck on thickness 5. It is very important. The growing of the endometrium, despite of the fluid, if you see, it means that you can expect some success and you can other things. This is very important. That's why you will have whether endometrium is growing or not. And then, so that's why in this case, I have cancelled the cycle, repeat hysteroscopy and laparoscopy was done. No hydrosalpinx, no tubular occlusions. Endometrial swab was sterile, TB-PCR was negative. So same case after I did one thing, in fact, I copied from one my very follower, this is Dr. Anil Gudi. I saw him doing, so same things I did. Letrozole 5 milligrams OD for 10 days, the extended use of letrozole. Idea was to give the multifollicular development. So I use estrogen cream instead of patch because patch is not available in my place. So transdermal applications, I give him BID, 2 puff like that, and endometrial cavity fluid disappeared, endometrium 8.8 millimeter on 12-day scan, and 2 blastocysts transferred on the 16th day. Luckily, pregnancy happens. So second case, 31 years lady, unexplained infertility except a very small intramural fibroid, ECF, cavity fluid before ET was found, no hydrosalpinx, laparoscopy and hysteroscopy normal, swab for infections negative, still 2 courses of antibiotic given, AMH was 2.32 nanogram per ml, IVF done, 5 oocytes, 2 blastocysts frozen, ECF continued, repeat hysteroscopy, ultrasonography, nothing, and ultrasonography, nothing is positive. So after 2 months, she reported, I did this time long down regulations, and provider was started to from the second day 4 milligrams. I started little ECF found on 8th day scan and aspiration. Then I did aspirations on the 8th day with an IUI catheter. Proginova 6 milligram done. Day 11 scan reveals no ECF, no cavity fluid. Aspiration, less SECF, still I did aspirations. Scan on 15, no ECF, very good. And endometrial thickness was around 8.1 millimeter. I saw triple line endometrium. So before injected, progesterone injected, blastocytes transferred on the 19th day, and pregnancy happens. So success. So the treatment plan, principle of treatment, what's the principle? First is rule out this hydrocephalus, very important, because how it hampers this pregnancy and implantations. Rule out infection, very important. Rule out intrauterine adhesions, growth like polyps and other things. And does endometrium grow in spite of this, your fluid? That is a very important observation you'll have to draw to proceed. And in this case, in 2 cases, it confirms the possibility of treatment. And transdermal use of estrogen works. Why? Why I have not given the oral? Because transdermal route is more physiological. It bypasses the first bypass. Prognosis, worse in hydrosalpinx infections, but better in PCOD. If the fluid is due to the hormonal cause, the success is more. So amount of fluid is also important. It is stated this if the amount of fluid in epidermal diameter is 3.5, better to scan cell. So if the cause is hormonal, I have said, fluid due to the reaction to the HCG and circulating estrogen, success is relatively good. Fluid in PCOD, okay, I just so these are the literatures I have collected. This is a very new.
1 minute more, please.
Pardon? 1 minute, okay. Risk factors for development of the endometrial fluid in women undergoing IVF. Conclusion is this: in association between PCOS, severe endometriosis, previous cesarean procedure, EFs, and also reporting from the first time association between the previous myomectomy. These are the associations of ECF. How to deal with the fluid of endometrial cavity delay? This is some during ART should be individualized according to the cause, appearance, time, accumulations. Important. And another thing is this is a comparison between the frozen and fresh. Conclusion is this: fluid accumulation seen in the fresh cycles are generally associated with better outcome because it may be associated with good prognostic factors. Small epidiameter of fluid with transient fluid accumulations and more with PCOD as an etiological factor. However, in frozen cycle, it can be associated with poor outcome. So in poor, this is in which case of frozen, the outcome is poor. But amount of fluid is very important, remember. Come to the last one. Here, the aspiration of the endometrial cavity fluid at the time of egg collection, you can do. This is good. I have experience. So yeah, at the time of egg collections, if you do this, good. So aspiration of the ECF at the time of egg collection is another new option for the women with ECF. It is updated the need of freeze-all or aspirate or the ECF at the time of ET. It was associated with the good success and can be new convenient options for the couples residing in the low-income countries. More studies are needed, of course. So our takes: ECF, endometrial cavity fluid before embryo transfer, has a negative effect on the success rate. Second, causes to be ruled out and treat accordingly. Idiopathic ECF can be benefited with high dose of estrogen, transdermal route, and with extended use of letrozole. Our experience with these two cases. ECF aspiration can be beneficial subject to the hormonal cause, amount, timing of these productions. And yes, there is more need for research and other things to come with the conclusions. Thank you. I confess we may know many things, but we do not know everything. Thank you.
Important aspect of the idea. Discussion part, because now I will request all the speaker to come over here to dice just for so after this there will be lunch day and from 2 years onward the next session will be inauguration of conference. All are requested to come today.
Kindly requesting all the respected speakers to come on the dais for a group photograph. Requesting Dr. Amal Fukan sir to be on the dais. Respected dignitaries and guests, we will be breaking for lunch now, which is served in the faculty center of our hospital premises. We will again join together at 2 p.m. for the formal inauguration of this wonderful conference.
Awasana tayo. Memory. Memory kita follow. Memory kita follow. Yeah, follow. One conduct. One conduct. এই ল'বলৈ ঘৰলৈ আহিছো ঘৰলৈ আহি পেলাই কামত মই বাক্সা পৰা আহিছো দুদিন কাম কৰি আছো ঘৰত ৰেষ্ট ল'বলৈ আহিলো কালি বিয়া আছিলে বিয়া মাৰি শুই আছিলো এটা নাই বন্ধ কৰি দিয়ে বন্ধ কৰি Ya basta eso.
Immigration
NEOGSCON আসছে এটা তার চাৰিখন আছে আৰু চাৰিখন ছবি লাগিব মানে 10খন ছবি গ'লে 10খন লাগিব
Looks like सबको दे ही नहीं रहे। अरे नहीं ब्रांड तो दिख रहा है ना कहते हैं ये बैंक क्या करेगा
Oi, pessoal. Itu lagi. Ya, boleh lah.
Someone. আমি গৈছিলো তই কি কিনিলি আমি দুটা কোনটো
যা যা ৰৈ যাবি আকৌ হেৰি আহিব নালাগে এইবোৰ অকমান আগৰে
আমাৰ সভাপতি হ্যাঁ ওটা সভাপতি আছে না
অকমান চুটিয়ে দিব লাগিব
অকমান দেৰি হ'ব বুলি খাব নাপাওঁ চব চালে চব চুটিয়ে আছে না Telepon lo ya kan soal kata. Bap.
ভিতৰত এই পঞ্চতলে কোপা আছে এই ভয় দিছ পঠিয়াই
বিলটো মই নাচাওঁ, এইটো সেই মোৰ হেৰিয়াত নাই, এইটো মেমক দিব লাগিব। ঐ বিচাৰখন নহয় বাইদেউ আপোনালোকক উঠাই গৈছিলে। বাইদেউ ক'ত গ'ল জানো, এইডোখৰতে আছে। বটলবোৰ খাই দিয়ক, বটল আৰু কাপ বিলাক, এই বেগ চেগ বিলাক থাকিব দিয়ক। খালি বটলবোৰ গিলাচ গিলাচ বাঢ়ি বিলখন আপোনালোকক কাক দিবলৈ দিছে? কাক দিবলৈ দিছে? শ্বেয়াৰটো সোমাব নেকি? ভালো ফটো বাদে নাই, এইটা উঠা না, আৰু এইটা উঠা দে। এইখন থাক, এখানে নেক্সট কাপখনে পিছল লৈ আছে। এই ৰুমটো Hello? ৰ'ব, খাবলৈ যাব হোৱা নাই, অফিচৰ মানুহখিনিয়ে খোৱাগে নাই, ইয়াত মিটিং কৰাখিনি। হেৰি চিন্ত এইটো পানীটো দিয়া পানীটো ভৰাই দিব তই চুপাৰ ধৰি লচোন উতল লগ নহ'লে বগা এটা লৈ আহিলে জেগাত খালী হ'ব নহয় বগাটো আনিব জেগাত খালী হ'ব বগা চুপাৰ ইউটিউবত লাইভ আমি কেলে লাইভ হৈ আছে পইচা বস্তু দে পাইছা হা কোন দিব ইয়াত তালি নাই ইয়াত ঠিক আছে দেখো এটা ভাল ভাল বলা নাই यहाँ
Purnia ada sini.
Yo, hari go.
Kita ada pansal aja.
ये पोलिंग नहीं करती
नहीं बेसी हुआ नहीं तुला बोलो पूरे वाला लोड करते लोड देखना है तो आपको बोले नहीं जाओ यार को बोल करना लगा
दामू के दे हे दामू के देखने जरा भाग मिल गया अरे अपन घर पे जाओ चलिए Aku itu nama bola sih. Kamu apa lagi nih? Kamu apa lagi? Kulumnya dua hari aku. Berapa bisa? Dua itu lagi nggak? Ada dua itu lagi nggak? Dua itu tahan kali. Oke, bagus.
itu wifi video কিমান জানো ৰবা মই ভাত খাবলৈ নাযাম মোৰ চেমিনাৰ আছে আপোনালোকে কোৱা থেংক ইউ আপোনাৰ ইয়াত ভিডিঅ' আকৌ চাই পেলাই লেপটপত মাৰিব পাৰিব বুজা নাই Hall Theatre, JMCH নহয় জানো? Would not connect, I can do it.
এইটো মেইন হল নহয় জানো? কৈ
Hall address 3.
অলপমান চাবই লাগিব নহয়। বৰ্ডছত বিল লগাই দিলে খুলি দিলে নহৈছেচোন। নহৈছে যে
তেওঁ গৈছে আনিবলৈ গ'ল
চৌকা
পটককৈ বস্তু আকৌ ইয়াৰ পৰা গৈ পাওঁ ফটোখিনি বাইদেউ সোনকালে বিচাৰিছে ইনগ্ৰেশ্যন কোনটো কাৰণে এইটো ক'ত হ'ব মানুহ গোটখা নাই তুমি আহা বাৰু তেওঁ মানে গৈছে সেইটো আনিবলৈ গৈছে
Wi-Fi password. Let's out sheet. আপনার মনে মেসেজ করে দিও মনে মেসেজ করে দিও JMCH itu mulai ya mulai termasuk yang bisa masuk
Aisyah.
Hello. Ya, kamu tuh Madinah, kebiasaan kalau beda ya, tidak kebiasaan cuma ini kalah hilang.
Kumbas sebagai dokumen.
Jika ujiannya bukan, tapi aku dokumennya favorit ada komputer tadi.
Apa nomor sih sulit kita? Suruh? Yes, kita perlu. Yes, kita perlu. কিমান দেৰি আছে ষ্টৰী কেইটা পৰা হ'ব 30 আগতে দেৰি হ'ব তুমি পাইলে এই ক'ত বাকেট লাগে এনেকে আমি আহিছো
नाम तो मेक्सिको तुम्हारे अभी खाली यही ना दे कि स्पेस का है कूलर हेलमेट का सेट कूलर को तो गाड़ी को प्लान पे ये खाली करता प्लीज अरे लास्ट कर ले
তোমালোক ইয়াত নেকি কলিংগে সিটি দেখো কিমান লাগিব
I will not say anything. No comment.
ডক্টর পিনাকি হ্যাঁ একটা কথা আছে না একটা কথা আছে এই মিনাক্ষী বাইরে বলছে তার না একটু দুধ পায় কম একটু বেলেগ কলার পায় রেড কালার পায় ভালো পায় তুমি তার বলেন আনলি जूट का दिया मैंने जूट का दिया लेकिन पता नहीं जब लोग दिया कितना करती है Thank you. Where are you going? First floor Special invitation. Nursing press to किसके लिए दीजिए? कौन सा वाला है?
মই জেবিতে পঢ়া বাইদেউ চিনি পাইছো মৃগাংক তাহাঁতত তুমি চৰ নমস্কাৰ চলি আছো ক্লাছ মোক তেতিয়া সকলোৱে ভাল মই এবাৰ ইলেকশ্যন
Thank you.
A very warm good afternoon to one and all present here today. It is indeed an honor to host you all today on behalf of NEOGSCON. As we begin our formal inauguration to the academic feast that we have witnessed, a host of wonderful dignitaries whose contribution to the society is immense in the field of obstetrics and gynecology. So without much delay, let us begin our formal inauguration. To inaugurate the session, may I call one upon another. First, let me call upon Professor Ratnakanda Talukdar, sir, Principal cum Chief Superintendent, Jorhat Medical College and Hospital, and Secretary NEOGSCON to take his seat on the dais. May I request one of our volunteers to kindly assist, sir. Next, may I request Dr. Bhavani Prasad Saliha, sir, our chief guest for the evening to kindly take his seat on the dais. May I request our volunteers to kindly help sir. May I request Professor Gokul Chandra Das sir to kindly take his seat on the dais. May I request Professor Novi sir to kindly take his seat on the dais. Sir, please. May I request Dr. Shashidhar Pukal sir, Joint Director, Jorhat, to kindly take his seat on the dais. May I request Dr. Arun Madhav Borwa sir to kindly take his seat on the dais. Sir is the Secretary of NEOGSCON. May I request Dr. Amal Pukan sir, Organizing President NEOGSCON, to kindly take his seat on the dais. May I request Dr. Pranavika Mohanta Bang to kindly take her seat on the dais. She is the Organizing Secretary of NEOGSCON. Now we'll begin our felicitation ceremony. May I request Dr. Bhargav Soliha sir to kindly felicitate our principal, Dr. Ratnakanta Talukdar sir. Thank you, sir. May I now request Professor Hemkanta Sharma sir to kindly facilitate VP Soliha sir. May I now request Dr. Debojit Chongmai sir to kindly felicitate Dr. Gokul Das sir. May I request Dr. Joyshri Singh Man to kindly felicitate our Joint Director sir, Dr. Sosidhar Pukon sir. May I now request Dr. Opurva Bhatta sir to kindly felicitate Novice sir. Ex-Professor P.L. Novice sir. May I now request Dr. Runjan Dole ma'am to kindly felicitate Dr. Amal Tukhan sir. May I now request Dr. Bornali Begum ma'am to kindly felicitate Dr. Amal Tukhan sir. May I now request Dr. Krishna Datta ma'am to kindly felicitate Dr. Pranadika Goswami Mohanda ma'am. Moving on, may I now request all the esteemed dignitaries on the dais to kindly light the lamp and formally inaugurate our session. I'd like our volunteers to kindly assist in the program. Thank you all my respected teachers. We now together invoke the blessings of the Divine Goddess by citing the melodious Saraswati Vandana. I request Digantika Datta to do so.
Varade, varade, Veena vadi, varade, varade, वीणावादिनि वरदे प्रिय स्वतन्त्ररव अमृतमन्त्रनव प्रिय स्वतन्त्ररव अमृतमन्त्रनव भारत में भर दे वरदे वरदे वीणावादिनि वरदे काट अंधुर के बंधन सर वह जननी ज्योतिर्मय निर्झर काट अंधुर के बंधन सर वह जननी ज्योतिर्मय निर्झर कलुष भेद तम हर प्रकाश भर जगमग जग कर दे वर दे वीणावादिनि वरदे नवगति नवलय ताल छंद नव नवल कंठ नव जलद छंद नव नव नभ के नव विहरविंद को नव पर नव स्वर दे वर दे वीणावादिनि वरदे 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 वीणावादिनि वरदे वीणावादिनि वरदे वीणावादिनि वरदे. Thank you. Thank you, Digamtika. That was indeed soulful. Next, we are also delighted to have amongst us a host of special invitees to whom we'd like to show our gratitude with a Fulang Namusa. I'd like to call out the names and I'd like our volunteers to kindly help. First, we have amongst us Dr. Assam Husani sir, whom would like to felicitate with a Fulang Namusa. Next, we have with us Mr. Bhava Goswami, Senior Advocate, Jorhat Bar Council. He is also the father-in-law of Dr. Pranavika Goswami. Next, we have with us Anjana Soliha ma'am. She is an educationist and mother of Dr. Mejaangkori Soliha sir. Next, we have Mr. Diganta Buramahan, President, Press Club, Jorhat. We also have with us Dr. Ajit Bora sir, Additional Chief Health and Medical Officer, Jorhat.
Thank you. Your presence has indeed made our evening even more grand. Next, may I request Dr. Amal Fukan, Organizing President NEOGSCON, to deliver the welcome address.
Respected President, respected Principal Arket Aludda sir, my teacher, Professor Bhavani Solia sir, Professor Gokul Das sir, the Joint Director of Health, Sosita Fukan, our NEOGSCON Secretary, Madhav Borba sir, our Organizing Secretary, Pranamika Mohta, and Professor Novis sir, and all the distinguished guests sitting here. It gives me immense pleasure to welcome you all to this 31st Northeast Obstetric and Gynecological Conference. Actually, Jorhat, this is for the third time it is being organized. For the first time it was in 1997, then it was in 2008, and this time 2022. There is a lot of change. There is a lot of palpable change during these years. And this is an era of change. We have seen tremendous change everywhere in all spheres. And this change is from imagination to innovation to discovery. As Albert Einstein said, imagination is everything. So we have imagined of such a beautiful medical college, and everybody has contributed to development of this beautiful medical college. And this is an era of change in the concept of technology and as well as patient care. And we can see so many tremendous technological advancements. Now we have seen that lot of newer subjects, newer subspecialties are also coming up. And it seems this is so faster than ever before. These things are occurring at a tremendous pace. And in this context, in this pursuing for the academic pursuit, so we are having all orations, talks, debates, and workshop. All these things we are arranging, and we hope that all the delegates and faculties, they will enjoy the change. And another one thing, for the first time this time in Jorhat, we have seen that we are arranging this first time Professor MP Gogoi Memorial, and I think it's a humble tribute from Jorhat Society to carry forward the legacy of Dr. MP Gogoi's dreams, and the person who has conceptualized and also crystallized the idea of NEOGSCON. And we are in a very firm position of NEOGSCON continuing into the near future. So I'd like to wish all a great success, and wish all delegates to have a comfortable stay and return back home with a lot of memories and a wealth of knowledge. Thank you so much.
Thank you, sir. Next, may I request all the esteemed dignitaries on the dais to release our souvenir. Dr. Binoy Kumar Bora, sir, is the editor of the souvenir. Can we hear a few words from you, sir?
So, good afternoon, everyone. So, it's my privilege and I am feeling a very immense pleasure just to present this souvenir on this grand occasion of the NEOGSCON 31st NEOGSCON 2022 that is organized by Jorhat Assam Society. Actually, this NEOGSCON, it is organized within a very short time. So it is seems to be difficult for us to collect this article and to make the thing organized for publishing this souvenir. But our team has tried our best just to collect the thing organized, and we have published it with some scientific articles, some review articles, some case reports, and we introduced for supposed to be not seen in commonly that we have introduced a non-scientific session also along with this souvenir. I tried to collect all the distinct scientific articles from various departments, like from gynecology, from pediatrics, from psychiatry, and from Department of Medical Education. This is newly joined in our college on Ancient Every College of Medical Science. And also we have that enclosed some articles regarding the history and evolution of the Jorhat and Majuli, that is the World Heritage. So that the delegates, they are coming from the east and every part of the northeast, so they will be able to know that's our culture and the knowledge of Jorhat. So especially I thanks to this team organizing committee just to give me the opportunity for this. And I have to especially thank Dr. Pranamika Koennak and my two postgraduate students, Dr. Nupur and Dr. Miranda. Actually, these people are the backbone during this journey of this souvenir to this point. So I want to thank you all, welcome you, and hope you will all back with a very sweet memories from Jorhat. Thank you.
Thank you, sir. Next, may I request Dr. Sasidar Bukwan, sir, Joint Director of Health Services, Jorhat, our guest of honor, to deliver his thoughts on this occasion.
Thank you. Respected dignitary and my teachers on the dais, respected most learned people coming from different parts of the northeast regions to this conference, and there are some of my seniors, guide, and teachers also sitting. And I'm very glad and honored to be here to welcome you for our district, and I myself be honored to take seat along the dignitaries of this conference. So I have nothing to say or regard. I like to request all of the dignitaries to look after to reduce the maternal, to reduce the infant death, where in Assam is a very worse position. We are in last up to October, we are around 63% ratio, and in infant actually we are in 20%, 20 IMR, our ratio is 20. Still then, though we are a bit better than the state and national level, still we are having lots of work, as we are having teenage pregnancy around 25%. So at least in the community level, if you can guide us to work to reduce the teenage pregnancy, it will help us. No more for it. I wish of your blessing to run this district in the community level, and that is my best appeal to you. Thank you.
Thank you, sir. Now it's time for all of us to immerse ourselves in the melodious chorus of Jorhat Medical College and Hospital.
Hello. Hello.
Hello.
Hello.
Thank you, dear students. That was indeed melodious. In the meantime, we have amongst us Dr. Jorhat, our special invitee. She is an advocate, social activist, and a filmmaker. May I request Dr. Parabika Konyak ma'am to kindly felicitate ma'am. Thank you. Next, I think the whole house is waiting to hear Dr. Bhavani Prasad Soliha sir. So may I request sir to kindly share with us a few words.
Principal Talendra, my ex-students, starting from Dr. Nabis, Gokuldas, Arun, and everybody, including Dr. Fukon, probably, the joint director, and all my learned friends here. It is a great moment for me, an honor given to me for asking me to inaugurate this August session rather of NEOGSCON. The idea was mooted out by my friend, Professor Mukti Prasad Gogoi. On the way when I was coming from Dibrugarh to Jorhat, I was talking to my co-traveler Dilip Gogoi that whether an oration is ever arranged or organized in the name of my friend MP Gogoi, who actually thought, worked, and organized this great assembly of Northeast Obstetrics and Gynecological Society.